Good.
Okay.
Mm-hmm.
Okay. Good afternoon, everyone. It's 2:30. We will now call, am I supposed to use this?
Only if you want.
Okay. We will now call this meeting to order. We do have a quorum present. So we'll now receive public communication from the ad hoc committee and for the ad hoc committee meeting. Do we have anyone signed up for it? Okay, we do not have anyone signed up. Thank you very much. We'll now proceed to the committee agenda. And everybody should have your committee agenda as well as your backup information. The first committee agenda is the approval of the minutes from the previous meeting that we had on April the 23rd, April 25th. Do I have a motion to approve those minutes?
You do? So moved?
Do we have a second?
Second.
Thank you, thank you. It's been a motion for approval, so with that, all of you, if you would please signify by saying aye. Approval of it? Aye, thank you. We will now move to the second item, which is to receive and discuss committee deliverables, including the development and the components of the philanthropy business plan, peer review, initial process, procedures, and update on other activities. I believe we have Ms. Virginia Potter and Kim Garbitz who will be presenting. Gabitas? Gabitas? Shoot, your dad, you either do it all in English or you do it all in Spanish. Which is it? Sorry about that. Let me just say this for levity purposes. I just got back from Laredo and I was telling the chair, I have never spoken so much Spanish in my life, and I go there all the time, but on this round it's very different. I spoke more Spanish in Laredo than I do when I travel to Mexico, so go figure. So I'm on a Spanish deal right now, so sorry for your name. Okay, if you will, go forward.
Hi, everyone. It's great to be back here again. And as a reminder, I'm Virginia. Lovely to be here, Director of Development on the Central Health team. So happy to be with y'all. And I have another colleague, Kim Gabitas, with us today. And before we get started, I'm going to turn it over to them to share a little bit about their background and what they bring to the table. So I'll turn it over to you, Kim.
Thanks, Virginia. I'm Kim Gabitas, happy to be with you all this afternoon. I've been with Central Health for about a year. Prior to being here, I was at Planned Parenthood of Greater Texas for 5 years, and then I was working with the State of Utah Governor's Office on a report for the legislature on federal and public funding mechanisms for science and technology development. It was really specific. But so that's where I was before. Now I'm here. You've all seen that slide showing our financial forecast for the rest of the strategic plan period. I was brought on to explore the possibility of new revenue streams. What I've seen over the last year being here is that we have a lot of opportunity to grow in this area. Grants haven't been a common source of revenue for Central Health, which there are upsides to that. We haven't had to manage restricted funds. We haven't had to deal with the extra administrative load of complex reporting that grants often require. But it also means that we're missing out on a pretty important source of funding that most hospital districts in the state have used to grow really quickly or meet the needs of their communities. So we could absolutely do the same, but we need to do so responsibly and judiciously. There are a number of different approaches that we could take that I've been exploring over the last year or so. A lot of what you're going to see today is what we have found investigating our hospital district peers in the state to kind of see what approaches could be best for us. So I'm going to let Virginia take the lead on this presentation for now, kind of walking through all of that. But that's the spiel. So happy to be here. Thanks. Kim.
Welcome.
Thank you.
All right. Thank you, Kim. So if we go to our agenda slide for today, I really want to make sure that we know that this discussion today is grounded in the bigger picture, really centered on the revenue generating effort that is the potential that we have for Central Health in the coming months. And you'll see that we're going to spend a fair amount of time together on the peer hospital districts, okay? And that will be really interesting because they're going to ground us in real-world examples, not just ideas of what could be possible for us, and we can make it our own. They're doing a few things. They're going to validate what type of an entity could be possible for us. They're going to give us clues as to what works and what doesn't. And they're also going to give us a better understanding of where we could be positioned in the broader Texas landscape. So although that today's agenda looks like it's a lot of individual pieces, right? We got our listening sessions with our stakeholder engagement, we got the peer review, we got the interim processes and a few other progress updates. They're actually not a collection of one-offs. They're all different pieces that will be part of our going forward business plan for whatever entity that this could take shape into to generate revenue outside of our tax base. And so we're really trying to layer all of these different pieces so that we have the whole broad picture and we'll be able to make strategic decisions together, having all of this foundational knowledge. So if we harken back to last time, our committee feedback on the next slide shows us what we talked about in the last meeting, what we heard from you, and so how did we land on what we're talking about today. Also in your packets, to really make sure that y'all have a deep understanding that we did hear your questions from last time, and we are taking them all into account with every step that we're taking. We have those in your handouts at the end of the slide presentation, so we know that those are on record and we're continuing to answer them as we go. And so in the last committee meeting, we really focused on the key drivers as to why now, why us at Central Health. And we talked a little bit about our development evolution, hearkening back all the way to 2012 and some of the things that we were doing. We talked about current state, and we came up with a timeline, and we said, look, let's do a very deep dive planning phase between now and November. And so you gave us feedback. You said, that's fantastic. You asked a lot of great questions around, well, what will our purpose be? How will we be different and governed than other peer hospital districts? And what would the financial and policy infrastructure need to exist to be able to do this? And so these are all the right questions to be asking at this stage. And even though we're not going to answer every one of those details today, please know that we have those folded into the answers that we are giving you. We're keeping track of those also to make sure they're layering into the different parts of the business plan, because this will indeed have the flow of a business plan, from the high-level summary, our market analyses, our stakeholder engagement, all of our risks, what our fundraising plan is, and how will we communicate about that. So we'll have the full-fledged pieces of the plan. And so what we want to make sure we do today is that even though each section of our agenda has its own focus, they are in direct response to the things that you asked us in the last meeting at the end of April. If we go to the next slide, y'all, hearing from our community was a huge part of the discussion at the end of April in the last community meeting. We want to make sure that we're grounding all of our understanding in what our community stakeholders are saying. And as you can see from this slide, these are illustrative examples of the stakeholder groups that will be part of these listening sessions. So during the month of May, we've been planning what will those look like. We are working with the other teams within Central Health, both our own team, which is strategy, as well as our communication teams and some of their partners in the community. And so those listening sessions will include members of the community. They will include funders. They will include some of our healthcare partners that are so important to us. And by having such a diverse range of voices, we want to make sure that we have a good assessment on what are the gaps and how do we pair this up with other things we have. We have a lot of great data from our community health needs assessment and those that will be coming up along the way. We will make sure that we're folding in information that you all asked about last time. How are we going to know about how populations are moving in and out of spaces in our broader community? So as a result of these listening sessions, we aim to really use that information to inform three main areas for us. One is our strategic direction in whatever shape this entity takes on. We will have a clear understanding of our role and value of this revenue generation opportunity. The focus areas. What does our community believe that philanthropy or flexible funding can unlock? What kind of impact can we make? And then in terms of structure, I think we'll also really get some information about how the entity could be governed and how it'll be aligned with our mission. Of course, it must be. If we go to the next slide, the plan is we've been working on this during this month to be able to come to you to say, look, over the summer, we will be engaging with these variety of stakeholders. We have not finalized the list yet. We aim to do this in conjunction with listening sessions that will be small groups of 8 to 12 people. And then we will also have some one-on-one sessions and some paired up sessions as well. And so as we gather this information, we want to be able to come back to you and say, hey, here are the things we're hearing. Here are some of the themes. Bring it back to the committee and say, what's your reaction? How do you think this plays into the overarching vision for the future? In doing these sessions and making it such a key cornerstone of the business plan and the work, we will ensure that we have our community voice and also the strategic needs of our community at the center. So, while the listening sessions will be fantastic, if you go to the next slide, and maybe one more, perfect, those listening sessions are going to be fantastic for us at the local level. But we also have to think about our state and what can we learn from our peers and also take their best practices and make it our own and make it better. Make it something that means something for Central Texas. And so what our peers have been able to share with us are real-world examples of what they're doing on the ground and how it's evolved over time, not just in terms of the structures that they have, but in terms of the partnerships that they seek and nurture, but also in the way that they deploy care. So let's take a look at what we've learned. And this work was started by the Central Health team some time ago last year with Ted and Pat and Perla. And Kim and I have kind of carried it on to dig more deeply into the development aspects of each of these entities. So these are our four major folks: Parkland, University Health, Harris Health, and then JPS. Let's start with Parkland. It might be the most popular, but I guess the most famous one across the country. It is the most mature district. If we go to the next slide, it's the most well-known because it's been around so long. The actual hospital district has been around since 1894. And like most safety net hospitals, it focused on primary care and access to training programs back then. But they really a foundation itself didn't start going until the 1980s. And it was formed with just one person, and that person reported to the government relations team within the district. And they mainly helped take in small donations and manage governmental grants. So it's come a long way since then, because this all started to change in the 2000s. In the early 2000s, they realized that their hospital facility, they needed a new one. It was becoming run down. They put out a bond. It failed. It was a little bit of a wake-up call. They said, all right, let's try again. So they try again, and sure enough, it passed. $700 million in public funding, and the foundation was charged to come alongside with $160 million in philanthropic funding. They were able to reach their goals in 7 years. And it was an inflection point for them in 2015 when the new hospital opened and they achieved their goals. They were like, what's next for us? We've built the building. What could be next? So they really, at that point, started to reflect on their role and began staffing up, strengthening their governance, and becoming much more aligned with the overarching hospital district's goals. So today they focus on things like maternal care, outpatient services, behavioral health, and they're really coming up with some exciting things and laying the groundwork in nursing as well as cancer care. So that's on the horizon for them. So keep in mind that they've only been doing intentional fundraising for 15 years. And as you see, on the slide that their annual disbursements are $15 million a year, 7,500 individual donors. So those donors could be an entity or an institution or individuals, right? And that's pretty, if you think that's impressive, it's even more impressive when we found out that for every dollar they spend to support their fundraising, they get $3.50 back. That's a 350% return on their investment. They are well known for this, and it's highly unusual. So in many ways, the Parkland model, in its maturity and its ability to be super efficient, is aspirational. And so Parkland's a great story, and I aim to tell this in almost storytelling fashion, so it'd be easier to remember all the four different entities we'll talk about. And really, they were the ones who came from being super reactive and turned themselves into a much more strategic entity, really thinking about how they could use philanthropy as a tool to drive change rather than this is the sideline project over here. And so when we think of another useful example, if we go on to the next slide where we have Harris Health, you'll notice we have two entities. And so Harris Health, as you know, is in Houston, and they have a unique approach because they've had a long-standing foundation for years. But just in 2023, they formed this Harris Health Strategic Fund. And it came about right after the voters approved a $2.5 billion bond to rebuild Harris's facilities. So the LBJ Hospital, renovations to Ben Taub, and then also upgrades and renovations to their 18 clinics across the network. And so I mentioned the foundation already. The foundation has a very distinct focus on community programming. They have a children's health fund. It's much smaller scale. They are nimble, so they can do a lot of disaster relief in the area. They host a lot of events. But it was really different. The strategic fund was built actually in concert with the development of the bond materials. And to go after purely capital efforts. And so the target was to raise $100 million in philanthropy over 10 years. I'm happy to say that even just at these early stages, like 3 years in, or 2 years in, they've already raised $43 million. And this is surprising because it's only from 10 donors. And so it's an amazing start for them. And the governance structure of the strategic fund is very tightly tied to the hospital district, with most of the board members being appointed by the board of managers. It still operates independently in deploying the actual plans on the ground through the strategy. It holds its own funds, it manages its own team. But it is a key strength that it has that great combination of both accountability, but also some agility there. They were super smart with their board. They ended up bringing on a board chair for the foundation who was very excited about the bond, was a key champion, had a lot of influence and deep understanding of what all the community stakeholders needed, wanted, and she was able to unlock doors to major commitments early on. She didn't ask for folks' attention very often, but when she did, folks listened, and it really has paid off. The fund started out with 3 staff members. It's still really small. They are employed by the fund themselves. They are not the network's employees. But they operate almost like a specialized unit within the network, but they're razor focused on that capital campaign piece. And when in talking to the executive director, Taylor McMillan of the fund, she said that she wears a secondary hat. She's actually the chief development officer for the network. And she's been given the charge to really think about what are some ways that the Harris Health Foundation and the fund could partner together in the future to not duplicate efforts, to think about better efficiencies, how could they have impact together. So that's still in the new stages of thinking about that relationship in that way. But Harris Health is an awesome example of starting really small with the foundation, staying focused, and then figuring it out when they had the bond opportunity to really expand what they were doing and go really big in the capital area and launch that fund. And I think it's interesting how both Parkland and Harris governance models are really different. So the Parkland Board is much more mature and also much more broad-based. We'll see a summary slide soon that really nets that out for us. And Harris built in the agility with a much smaller board with a strategic fund, but it operates with a lot of great accountability to the network's board of managers through appointments. So they have the best of both worlds. If we continue on into the next slide, we have University Health just south of us, right? So they're an excellent example of how a hospital district foundation can evolve quickly. So Sarah Alger, the president, when she stepped into that role of the foundation, this was about 5 years ago, really didn't have a lot of structure. They were very focused on their annual gala. They had a fantastic employee giving program, but now they have built their team into a real modern fundraising machine in a super short time. They focus on patient support, innovation, and when we say innovation, they support things like medical technologies, research, of course, community programs, and capital projects. But one of the biggest shifts that occurred with Sarah joining is that she became really integrated with the strategy team. And that really was unlocked by the chief communications officer, who really brought her into the fold to say, hey, if you're gonna be thinking about these revenue streams, you have to understand the broader picture. And you have to be thought of as part of this team with us. And so that has really changed the game for her to be able to activate and really grow the fundraising ability there. Governance-wise, University Health Foundation operates distinctly underneath the network as an umbrella organization. The network's the umbrella organization. And the board of managers appoints the foundation board. It gives a clear line of accountability, which is nice, but it also gives the opportunity for some agility. And you say, okay, how does that agility show up? Well, Sarah gave us an awesome example of the Uvalde tragedy. Sadly, she said when that happened, they got a lot of unsolicited donations. And we're like, oh, gee, what are we gonna do with this? We wanna help people. Well, in partnership with the community, they made a point to figure out how they could deploy funds for behavioral health and youth services, and created a plan that they went to the board of managers, both the foundation board and the board of managers came together and said, this is the right thing to do. So they were able to find the way to remain nimble in a state of disaster and crisis, but also kept full transparency with the board, and were able to show how relationships in a time of need could work. And one of the final points that Sarah made in our chats with her was around foundations taking much more than money. And I believe all of us in this room understand that so well. It takes trust, it takes community connection, it takes being super clear about what we would fund, no matter the entity, and what we wouldn't, because that clarity will give us a ton of credibility in the community and respect. And so University Health really shows us how a very community-conscious foundation can make a lot of great strides in just 5 years and still retain the ability to meet community needs when the time is of the essence. And so our final one, if we go to the next slide, we see JPS. And so JPS is another great example. It's actually been around for decades, and not many people have heard a lot about them, except for probably folks in this room. And they're in the midst of reimagining and rebuilding what they could be. So Leah King is their new leader, and she comes to the organization from United Way, has a ton of private sector experience. And when she got there, she realized there was a lot of opportunity in governance, staffing, and in the strategic direction. So on our call, she said, I realized I inherited a foundation that had a lot of heart and a ton of history, but no roadmap. Yes, go for it.
Pardon me, what does JPS stand for?
John Peterson.
Okay.
Yeah, thank you.
Thanks.
Great. No worries.
That's all right. I just didn't know.
There, yes, Yes, it doesn't say Fort Worth here, sorry, y'all. I had it on the other slide. They're in Fort Worth. So, and some interesting things, while we're talking about it, we checked out, y'all probably know this, but Fort Worth is a very interesting comparison in terms of size to Austin. About 1 million proper in the cities, and then about 2.4 for us in the metro area, and 2.8 for them. So interesting in size of population. We were starting to look at that too. That was one of the reasons why we started talking to JPS.
That was just a recent change in population.
Yeah, right?
If their politics is very different.
Very different. Yeah,
I just say that because Austin was number 10, now Fort Worth is. So I just thought, I think that's important to note.
yeah, I agree. Thank you, Manager Jones. I do think that's a good call. JPS is, I'm gonna call this out, it's a 501c3, so it is a public charity, but they've also applied for 509A3 status. And it gives them the ability to be a supporting organization of the health network. They can have both of those statuses at the same time, and it does give them more flexibility. We're gonna talk a little bit more about legal opportunities and the way structures are, could show up for us a little later in the presentation before we close. One of the interesting things Leah talked to us about is how she's reimagining some of the roles and thinking about less about calling major gift officers on her team major gift officers, and thinking about more of a donor relations standpoint. That's a key thing when you're thinking about building up relationships and thinking of shifting a relationship from being really transactional to something much more mission focused. Right now, the foundation has a $1.5 million annual disbursement, and they have about $500,000 each year now in in-kind donations. And that's mainly in their women and infant services line. They are embarking on a new strategic planning process. Part of this is in part that the bond that they passed in 2018, that was a $2.1 billion master plan facilities bond, is now gaining a lot of momentum with the new psychiatric emergency care coming online this summer, and with new hospital towers coming up in winter 2029. So they need to be thinking about who they are in the community, how can they meet needs more quickly. And so it's great to know that we actually have someone else who's rethinking a lot of their processes and figuring out who they are to the community as well at the same time. And so if we go to the next slide, this is a deeper dive into several of the hospital district's philanthropic models. But this slide isn't meant to rehash the details we just went over. It's meant to give you a nice summary slide to read and reference in the future, but also it gives us an opportunity to step back and say, wait, there's some patterns here. And what are those? So a few things that stood out to us were every entity is structured a little differently. Some are longstanding foundations with community focus. Some are razor sharp focused, like the Strategic Health Fund in Harris Health. In terms of scale and maturity, Parkland's definitely the clear front runner. But when we see the success that Harris Health Fund has, I just butchered that, Harris Health Strategic Fund has had with raising $43 million in just a couple of years, that's exciting to see a newer entity kind of punching above their weight. We know that board structure matters. Most entities have leadership directly tied to the hospital system. That's very important. And yet they also include community influencers and philanthropists who can open up access to and build those relationships with the funders. And finally, each one has their own its own philanthropic identity. And so some focus on patient holistic wellness, others focus on innovation in medical technologies, but each one has to think about what the region is needing and how can that build for their case for support. So I think the key takeaway is there's no single formula here, but all of these different hospital districts have strong system alignment with their system, with the networks, strategic clarity, and the boards have a huge passion for the mission and ability to fundraise. And the last slide of this section before I turn it over to Kim is really about, last meeting, we had a conversation about clarifying what kind of revenue generating entity we were actually thinking of. And so would we be grant seeking? Would we be subsidizing current programs, targeting new things, focusing on capital? And so this is a summary of examples of that. We see Parkland as a towering example of focusing on grants from the external and building a huge base there. Subsidizing programming is really about JPS. They are such great organizers around filling gaps. When we look at innovative services, University Health focusing on medical technology and research and bigger, bolder ideas has been something that works in their region. And then finally, with Harris Health Strategic Fund, we have the capital projects. They created the whole fund explicitly to do, to make sure that they could follow that through and achieve those goals over 10 years. And so it really, it's not, there's not one solution that's better over another, and perhaps the best solution is some sort of combination of these that works well for us. And there was so much to share about this that we actually offered up some additional information in your handouts that you can read at a later date. We offered up more detail on the strategic funding approaches that you see here. We offered additional summary profiles of the peer districts I just went through. And then we offered a comparison between the hospital district and private health foundations. So we would have that as a basis. So it's not about making a decision today, like what's the right structure for us. We need to make sure that we're grounding our next steps in our direction on what we hear from our listening sessions and our stakeholders, because they will help us determine what the best models that we could have to meet the people we serve at this point.
Virginia, I'm going to ask y'all
Yeah.
to pause right there.
Yeah.
And let's ask for questions from the committee if we would. And I'm going to start with Manager Jones on this side if you have any questions, and then we'll just kind of go around. If you want me to start on your side, or you want me to start on the other side?
On the other side.
Okay, no problem, no problem. Then I'll start with Manager Rodriguez.
I'm not sure if this is a question, but I think, thank you for laying all the different types and their approaches. I think one of the things that I think kind of goes through all of them is they were all started because they had a why. So I think for me, I maybe, this might be a question for later, but what's our why?
Yep.
Is the question that all these kind of presentation and the string is all, they all had a why to it.
That's right.
But thank you for the work.
Manager Valdez?
One of the questions that I had, just kind of off the cuff, is how are the various initiatives and these various programs, I mean, how are they interacting in such a way so that there's not duplication by the boards, the healthcare boards, and then the foundation entities? So that there's no duplication, there's complete transparency and accountability. There's community engagement and involvement at all levels. And I guess, how are they determining what the projected need is? And then I just had a silly question. You kept referring to networks. So what do you mean by network? Are you assuming you put them all together and it's that network, or what do you mean by network?
Yeah, that's a good point, because I was using that word, I think, in different ways.
Yeah.
I meant the hospital district. So
Okay.
when the examples on the slides that went into each entity, those were the revenue generating arms or entities affiliated with the entire grouping. But I meant the way I used it was meant to be about the district, yes. Thank you for clarifying.
So that's important then
Yep.
for me. because I want to make sure that we're not going to be using the philanthropic arm to not do our jobs
Right.
as a board, as a healthcare
right.
district. We want to make sure we're taking care of our patients
Exactly.
and their needs first, and then whatever
Right.
is gravy. But then again, it could be, it's strategically used, so that we don't have to do this. It's a shortcut. I just want to make sure that it's not duplicative.
Right. No, it's a good point.
And with that, I'm gonna raise this question,
Yeah.
just so that we're clear, or it's clear, I
Yep.
should say. So she raised a good question. She wants to make sure our service is not duplicitous, but at the same time, I would see this work that we would be doing through the foundation, i.e. the fundraising or whatever funds come forward, the way I'm seeing is, it's going to enhance other services that we don't have funding for. Is that a correct assumption on my part?
It could be an enhancement, it'd allow us to serve more people, it could be both. But the point is, Manager Valadez, were you gonna respond to Manager May? Sorry.
I'm sorry, I understood what you were saying, and that was one of the reasons I said, that's why I raised the question, because I'd like for us to be, as a board, very clear about what we're doing here as we engage in this process going down
Yeah.
the road, because one of the things I don't want to see is a future abuse,
Right.
and by people who don't have a fiduciary responsibility
Right.
for the use of the dollars
That's
that are being raised, and that's what we have, so.
So it'll be incumbent upon this
I
committee
want
to
to make sure there's a
determine-
check and a balance.
Yeah, but it'll be incumbent upon this committee to determine the direction of how these funds will be used.
The
Based
board.
on the data, right.
It would be incumbent upon the board to decide.
Moving it
As-
forward to the
As
board.
opposed to what I'm hearing, what I'm seeing, and I know that you can work very closely together, and that's fine, but what I want to make sure is that there is a clear understanding and a delineation.
Right, and just to make a
No, go ahead, and then I'll cut in.
Okay. I completely hear you, and you're picking up on a theme that was very clear to us too. That a lot of these organizations found, oh, wait, we don't have enough connectivity. We do need to have a deeper level of understanding. And so when you heard the description about, oh gosh, they're reimagining how they should do this, is because of what you're saying, in part. And so I think we do have to be very careful, and definitely weren't trying to hold up any of these examples. They're all great in their own right, and they've all had a journey, and they all are going to continue to do amazing things. But they are illuminating and shining a light on the opportunity to be very clear and transparent. So I think that's a great point.
Thank you very much. At some point in time, I'd like for us to see how they break it down per district. Thank you.
You're welcome.
And then if I can just, oh, I'm sorry.
Oh, she was gonna answer.
Oh, okay.
Just to add to that a little bit, I think some of this comes back to what Manager Rodriguez was saying about them all having a very specific why. Part of avoiding the duplication here is based on the fact that these entities have very different purposes functionally. They share a mission most of the time that is very explicitly about the responsibilities that a hospital district has, but fundamentally, one of these entities is made to raise money. And you'll also notice that there was a common theme of supplementing a bond. So Parkland, JPS, and Harris Health all had this where they were putting forward a bond to build a new capital project, a new hospital, a new specialty center. And the bond itself was not quite enough to cover the full cost of the project. And so the foundations or fundraising entities played a huge part in meeting that additional need. And I think that's the clearest way to illustrate that difference. That's maybe not necessarily going to be universally true, but just kind of as an overall idea or archetype of what these relationships look like.
I appreciate you saying that, because when you say that, I hearken back to the bond election that we had, and the $35 million that we don't get to see how that money is spent, and we just give it away to somebody else who's gonna spend it however they want without any accountability to us, and those are taxpayer dollars. So I want to make sure we do not end up in that kind of a situation. Thank you.
Thank you, thank you. Vice Chair Brinson? Okay, Chair Kitchen?
Just a few questions. Would it be possible, and I haven't read through the backup, so you may have this in the backup, but I'm curious about just a couple of pieces of information that maybe you could give to us offline or after this. I'm wondering if you have information about number of donors and average gift size. If you have that kind of information, that would be helpful.
We have some of it, but we can get it.
Okay.
Yep.
And then the second thing is, I would like to see the bylaws for these other organizations. And what I'm looking for is that will help me understand how what tools they've used to be tied to the boards of their organizations. So can you provide us with the bylaws?
Yep, we definitely can. We have some of them already.
Okay.
And I think a potential way for next steps too could be spending some discrete time around the bylaws and some of the legal pieces as one of our next sessions. We can talk about that more, and we can work it out with Manager May as well. But that could be a consideration, because we're getting so much foundational information that we're anxious to go to that next step and say, okay, what else can we know?
Well, I'll leave that to the chair. Y'all can decide that, but
Okay.
I'd like to actually see
Have
the,
the documents. You
just
got
see
it.
the bylaws, and then
we
y'all
can
can
get
do
those.
whatever you think's appropriate in terms of how you talk about that.
Great.
And then the last question would be, and I don't know if you have a way of knowing this or not, but I'm curious about how these entities interact with their communities and how they, because one of our concerns or thinkings is that we don't want to compete with our partners, particularly in an environment of scarcity. So do you have any information about how they've managed that?
We do. We
Okay.
can summarize it for you and share it, and if it ends up that you want more information, we can augment it.
Okay,
We do.
that one, can you tell me anything right now about that, or is?
Yeah.
Okay,
There, I would say, probably the one that springs to mind first might be JPS and the Harris Health Foundation. So the Harris Health Foundation has a specific children's health fund that they've created, and they aggregate dollars across different nonprofits and work with them in that way, and do a lot of community engagement. So they have different kinds of events that they bring the community together. They share their top priorities and goals and get input. Likewise, in terms of JPS, because that's kind of been their bread and butter for so long, it's very similar, but different types of pieces. Some is around cancer care, some is around maternal and childhood health, where they are engaging very deeply and bringing, convening different nonprofits and community members together. So we can give you more information that I think they have actually publicized on some of these things that can give us a sense. I feel like I know less about how the Strategic Fund and Parkland has engaged, unless, do you have any nuggets? Those are,
I don't know that I do.
yeah.
Yeah, I don't think so.
do you know if any of them have encountered issues around competing with other partners in their community? That may require some more conversation, I don't
Yes.
know.
I
But
don't
that
know
would be one, Chair, that would be one thing I'd like to understand, is if they've run into those kinds of issues and what they did about it.
Yeah.
Okay,
We can
Thank
dig into that in a conversation with them.
okay,
Yeah.
thank you.
Just very quickly.
Yes,
and
ma'am.
That was the reason I raised the question, was specifically to the UT Medical School and Central Health.
Yeah.
Very good, thank you. I have just two, really, I'm gonna just ask one question. It's from the very beginning of your slides, where you're doing your stakeholder engagement. The primary question that I have is, what is the tool that you're using to gather that data? And then how, once you gather that data, and what are the different functions that that tool is going to work for the organization? In other words, how will you be using it, not just for us, with respect to our philanthropic work, but also with the other portions of the organization?
This, the listening sessions are being done in conjunction with the communications team. The communications team and the strategy teams were already partnering on ways that we could engage the community, different stakeholders in the community to be thinking about the future role of Central Health. So being able to ask in small group discussions, small group listening sessions that would only have 8 to 12 folks. Some would be one-on-one sit down, some would be small group. So that we have a partnership with an organization named Digital Advance who's partnering with us. They're still in the planning stages with Monica and Ted and the Digital Advance leadership. So we don't have all of the logistics ironed out, but over the next handful of weeks, the plan is for those sessions to occur. The information would be aggregated by Digital Advance and us jointly. And then we'd be able to produce an analysis of what the key themes were, how many folks we talked to, making sure there's clarity around the stakeholder groups. So it's in-person, one-on-one sessions or small group sessions.
But essentially, the tool itself, you don't have, it's not been created yet.
They are in the midst of creating the guide
Yeah,
right now.
okay, that's
Yep,
okay.
we're at the tail end. We're
Yeah,
getting close.
That's just, it's just good information to know.
Yeah, no.
Very good. Yes, ma'am.
Question. So they went through an engagement process.
That's right.
So can they provide you with the tools that they did use?
They haven't conducted it yet, but they will. They're planning for the sessions.
Yeah, I think that the engagement process that we've just gone through is different from what they're planning to do.
It is.
Yeah.
Those are two separate.
And so from my perspective, I'm just seeking to understand if we're using the same tool we used last time for those sessions as you delve into this new component. That's what I'm seeking to understand.
To my knowledge, I don't think so. It's not the same, right? It'll be different for
Okay.
this purpose, right, y'all? Okay. Conferring
Thank
with
you.
my
Yeah.
colleagues, yes.
Yes.
They'll be different.
Okay, thanks. Manager Jones. Thank you.
I should have went first.
Oh, no.
All
Next
the
time.
questions, many of those questions have been answered. But you did. First of all, thanks this is very, very helpful and very informative. A couple of quick questions. One is, and I'll declare, I worked for Harris County Hospital District back in the 90s. So I have some connection with that, when Lois Moore was the CEO and things, so I have some, many, many years ago, but, so I have some familiar, not with Harris Health at that time, it was a hospital district. But one of the questions I would ask is a question of accountability to not just the taxpayers or the foundations, but also to the citizens, to the participants. Is there a way, or are these districts, do they look at evaluating the effectiveness of what they've said they're going to do by raising these dollars to be able to accomplish these things? And who holds them accountable? Their boards, or is it the board of managers for the district?
There's a lot of layers to that one, and I like the question. In the case of the districts we've talked with, they have measurement and evaluation plans that accompany their work. And so they produce impact reports, much like we've seen with other entities that we all know in this space. And so that's one mechanism for being able to do that when the priorities are outlined at each year
fundraising and programming moves forward, and then there is an assessment portion that would have qualitative and quantitative information that would be part of that report out that would be shared publicly. Who holds them accountable? So the fundraising or the revenue generating entity would have its own board. But as we saw with these different models across the state, there are different ways that accountability could work. It could, most of them have the CEO of the hospital district on that, for purposes of just making it easy, let's say foundation. But on that foundation board. There, within the structures, it's also dictated how many board seats on the foundation board would be appointed by the hospital district's board of managers. And so I think there are ways that it would actually be a multiple layer. There's a public sharing of, hey, here's how we did. As this entity, there's the actual fundraising entity board, and then there's the board of managers. We see that one of the best practices is when the board of managers and this fundraising entity board are linked very closely and are in alignment, good things happen. And so I think it is a multi-tiered set of accountability structures that would help with that.
Okay, thanks very much. These are five different communities, different size, different demographics, different populations, different geographics. And so I guess my question in terms of, do you see trends based upon those things in the development of boards? For instance, Harris County is a very wealthy county in terms of resources. And so they have ability to do things that maybe Tarrant County or Fort Worth may not be at the same. Does that come into play in terms of the viability of these foundations?
It does, yeah. And I think that the examples we have, when we think of Fort Worth, even whatever we're gonna say about the similarities in size to Austin, but Fort Worth, Dallas, Houston, and even to some degree San Antonio, all of them have much longer histories, especially the first three, of legacy giving and a philanthropic, like very deep philanthropic pockets in those regions. And so Austin's a newer city, philanthropy is newer to us. And so you're exactly right. It is a risk, but it's something we're keeping in mind when we're thinking about, okay, what's the viability of how much could we actually raise for the unmet needs that we have in our region? As Central Health to meet our population's needs, I think we have to take that into account. Would we be able to raise as much as those other regions? I think that's part of the feasibility that we're doing.
Two more quick questions. One, it goes to my colleague, Manager Rodriguez, when he asked the question, why? And I would ask the question of politically why. In other words, were these done for the ability to meet certain expectations that the politicians in the community wanted to help defer the cost for tax purposes otherwise? Or was this done primarily to truly address the issues of the needs of the community and who's driving those kinds of things? Are those factors that you are able to assess at all? And I would imagine it varies from city to community to community.
Yeah, no, you're raising a great point, and I do think that the why that we'll land on will take the components of all of these pieces we're talking about, especially the stakeholder engagement piece. And you're right to layer on the political side of that. Is there another consideration? For sure there is. And I do think it's different for each region. All of them, in our discussions with them, have started with the fundamental basis of the need that their community had. And I think, as we all know, there will be other variables at play. Of course, politics is one of those. But at the very fundamental and basic level, it started with the need, to our knowledge. But it's something we have to consider in our journey as well.
Okay, and the last question is the community understand the structure, the difference between the fiduciary responsibility of that board and that of the hospital district board and how they interplay? at all. I remember in Houston being very politically active and getting the boards, not the board, because it didn't exist at that time, but the hospital district board particularly engaged. Does community play a big role these days? Not in just Harris, but the other ones as well.
In Harris and in Parkland, we've gotten more of a sense that community does play a role, only because they talked about it more. So this is something we can definitely go back to them on at all of the districts and dig in more deeply. But many of the fundraising entities have community members, whether they're active members in the community who take part of the services that the hospital district offers, whether they might be a funder or a business leader. They have a variety of seats that they can occupy, so that's exciting. But at the end of the day, does the general community understand the differences? No. And I think that's an opportunity, right? There's an opportunity for educating, there's an opportunity for inviting. How we're trying to lead with this in every conversation we have is that be a part of this exciting time with us. Central Health has the opportunity to grow and meet the needs of more people in our region. So be a part of that with us.
And this does touch on one of the subjects we've talked with Leah King at JPS about. When she came in, one of the big things that she's working on is specifically raising public awareness and delineating the difference between the two. What her role is, the fact that she exists at all, what the strategy is there. That's one of the number one issues that she faced when she first came on board. So there's also a lot of productive discussion to be had there. And it's absolutely a discussion we're going to have.
Thank you.
Thank you, sir.
Can I ask one more question? Is that okay?
Yes.
Okay, just one other question that this made me think about. And this may be something that you already have planned, or you guys are, if it's already planned, you're gonna say it in the future, you can just defer. But I'm wondering if at some point we can get a description of the environment in Austin for philanthropy. And you would know better than I what those key factors would be. But it'd be helpful to understand what the environment in Austin is for philanthropy. Is that possible to?
Definitely. It's on our planning
Okay, great.
list. It's
Great.
one of the bullets, but thanks for saying it because it just reinforces that it is important. Yeah,
And then does El Paso have a foundation?
they do. So there's a page in the handout, there's several in the handout, and we have kind of the top 10 hospital district foundations as well as some of the private health foundations listed, and El Paso is in there.
Okay,
Yeah.
thank you.
Yeah. Let us know if you need additional follow-up or more info on that.
So with that, I'm going to have you continue your presentation so that we can keep this meeting going.
You got it. Thank you. Over to you, Kim.
Yes, I will take it from here. If we want to pop down to the next slide. So that was obviously a ton of information to chew on. You have those extra packets as well that have so much more information that you can look through at your leisure. Let us know what your questions are. We can build on that. For now, while we're going through this whole strategic planning process, identifying how we want to do this, we can still support the health equity strategic plan. We can still be meeting those gaps. There's no reason that we can't be fundraising now. We don't necessarily have to wait to build a foundation or a fund or some other entity to do that. So what we have here is a proposed interim process for reviewing funding opportunities as they are presented. We've set 3 specific points here that we think are going to be the best to guide it. With the intention being essentially if any given opportunity checks one of these boxes, it comes to y'all for immediate review. So the first is a financial threshold. It's very simple. Opportunities over, say, $1 million, but we can adjust that to whatever feels appropriate. Come to you all for review first. The next is reputational or ethical questions, and to be very clear, we don't ever intend on ending up in that kind of left-handed box. It's far more important that we, stand next to our patients and communities that we serve than it is that we chase down any given donation, no matter how large. But if there are ever concerns, we would bring that to you all and let you give us your judgment before we move forward. And then the last is operational complexity. If it's a project that is fairly high risk, that is an untested model, that would truly exceed staff limits, that is something we would also bring to you. In the case that it is less than $1 million, aligned exactly with our values or a partner that we've worked with before, and it is a proven model that we have the capacity for, we would want that to be a staff-led process. And in that case, it would be brought to you all in kind of a funding update and a status update. We are going to hit one of those in a couple of slides from now. But that we would keep staff-led so that we can be nimble, move quickly, make sure that we're still engaging you all when it's very important. So if we pop onto the next slide, this is kind of the...
I'm gonna
Yes,
pause you.
please.
Pardon me, I'm gonna pause you there because of the importance of this slide. Committee members, do you have any questions or thoughts about the information you're seeing on the slide? Okay, in that case, I'm gonna start. Mr. Jones, may I start with you if you have any comments or concerns about the slide you're seeing? After your colleagues, okay. All right, here we go. Mr. Rodriguez, I'm gonna have to start with you again, if you're okay with that.
I have like 3 or 4 questions.
Okay.
So
Recording stopped.
financial threshold, when you, just to get,
What part?
oh, sorry.
This needs to be recorded. Somebody think we were in executive session?
Sorry. Manager Rodriguez, we're back on. If
Sure.
you have any questions, or you do have questions, I believe.
Sure.
Comments.
I think these are probably comments, or maybe there's questions in it, but again, I really appreciate all the work that you all have been doing on this. I think as we all, in one
Recording
way,
in progress.
discern this issue and also co-create it at the same time. Like one of the, and I was reading some of the other slides, one of the threshold questions I have that's not financial, but is like, a threshold question is whether this is a federal, state, or private dollar. Because I think if you think about the federal and state pieces, the in-kind cost associated with that is tremendous. So if you're just starting off, and I don't know the history of Central Health, but if you're starting off and doing even $100,000, $500,000 grant, you're already behind in the cost issue, and taxpayers are taking on that burden because your federal and state will have a lot of requirements that, without getting ahead, your staff should probably be more than double what it is now in order to comply with those legal regulatory issues. So one is like whether it's federal, state, or private. I think the other one that at least I've learned in my public service about financial threshold is to ask the question of, and I know you put $1 million here, is it $1 million within a fiscal year? And what's the time period? And then secondly, just from my perspective, and again, for discussion purposes, for me, if you're in a multi-year grant, I mean, that's a fiduciary duty, and there ought to be some issue there, whether it's $5 or $5 million. So these threshold questions are really good, and that's where we ought to be spending a lot of our time discerning that issue. And then as a governmental entity, you have a certain, and I think it's the same, but there's a percentage reimbursement that you can take in addition to the implementation of the grant, and that reimbursement percentage should somehow be, there should be a transparency around that issue. And the last thing I'll just say here is that I'm really appreciate the way y'all are discerning this. I think the clarity around the costs associated with taking on grants, there's gonna be some that you may just say no, because great topics, great issues, great impact, but the cost issue, at least if it's not, if the board doesn't discern and make a clarification that, you know, we're getting a $500,000 grant, but we're also needing to put in $250,000, so it's really a $750,000 cost issue. It's just something to think about as you're doing all this. But again, you all are in the alignment to the mission, values, and strategy conversation, which is where we ought to be with the board in terms of governance. And some of these questions might be more for the implementation or the tactics pieces, but I still see there's an integration there as well, so.
I do have an immediate response to that. In the sort of internal process that I follow as I'm evaluating a grant opportunity, one of the very first questions is kind of the ROI, or whether or not the juice is worth the squeeze. And we have already passed on probably a dozen opportunities that would maybe not be worth it for that reason. And it is one of the number one questions when considering, as you mentioned, federal, state, private, is that administrative burden, because it is enormous with federal grants in particular. So yeah, that's absolutely, it's an item on my checklist, and we will be adding it to this threshold list as well.
As far as I'm concerned, when someone tells me things are staff-led and then they don't bring it to us and we have not approved it, that's a big red flag for me, because we have been receiving information from our CEO that speaks to the fact that we have staff that sometimes is overburdened. And so, does that mean new staff, different responsibilities, blah, blah, blah. So as far as I'm concerned, and since we are the only ones that have the fiduciary responsibility for how our tax dollars are spent, there should be 0 here for staff-led, okay? You have an employee that has responsibilities. If they cannot do their responsibilities, then we get another employer, we change the way the structure is created to be able to handle that. That's just off the cuff. So I'm sure I will have a lot more questions or concerns, but that's it for me right now.
I would just also suggest that adding under the board reviewed criteria is, I think, what Manager Rodriguez mentioned, the multi-year grants and federal, state. I'm not sure we need to know if they're federal, state, or private. I'm trying to think about which ones the board would want to review, maybe the federal and state. Is that what you were thinking, or?
Well, I think there's still discernment to be made about approval and then just transparency to know.
Yeah,
So I think
yeah.
that's still out there.
Okay.
And then the other thing is here is, I can't believe I'm saying this, but in today's world, like the enterprise risk management of like the potential of these grants, you're getting them, you're applying, and then all of a sudden, what's the causes for them pulling out? So there's a risk assessment associated with the probability that you will actually implement or get the money. Or not get the money, but you can draw down the money.
Yeah.
Given kind of where we are.
Then I would just add one other thing under the ethical issues or controversial funders. I would expand that to be, and I'm not sure how to articulate it, but it would be in any that have some sort of sensitivity to them for Central Health. And that could be for a whole range of reasons. It might be something that is potentially where you've got the risk of competition with other folks in the community, or there might be something else about it that's sensitive. You know, understanding that would need to be defined a little bit more, I think we need to add that That would need to come to the board.
Excellent, thank you. Manager Jones?
Sorry, just a real quick clarification. Manager Valdez, you were drawing a distinction and saying that the board needs to see pretty much everything under the statute. No gift of any size can be received by the district without the board's approval. It's in the statute. So I don't know if there's a
No.
distinction between reviewing and
Well,
approving.
Or,
yeah,
wait, I think if I may, the question could also be, we have to review anything, and we have to approve what gets received, right? But I think, I'm gonna draw the distinction is before we do the ask, to review that. I'm looking at it from before the ask goes out.
Yeah, I just wanted to point out the
Yeah.
Yes.
acceptance has to go through the
Okay.
board.
And
Am I,
just to-
did I make that clear?
Correct, you got it right. And additionally, I want to make sure we don't have staff people who are out there looking for donors because it's going to be a way to fund themselves. The same thing with the donors, looking for an entity to do a project that they themselves administratively don't want to expend the money on. So we're being used to do the work. No, thank you.
Thank you. Manager Jones?
I just have one question, and it piggybacks off of what Board Chair Kitson says as it relates particularly to finding ourselves down the road, wanting to do something that in Austin or Travis County or Central Texas even is ethically, politically advantageous, and we have someone sitting in state capitol or someone sitting in Washington saying, I don't know, we want to be having our governmental bodies going into that type of thing. We're seeing what's happening now in many ways in terms of the educational community. It is conceivable that same kinds of concerns could be addressed when you look at the health community. So I just want to elevate that so as we think about these type of processes, profit or nonprofit, down the road, we don't know what we're facing, and we need to be mindful of what challenges we might be facing. So I just want to raise that issue.
Would staff like to comment, or can we move on?
Yeah, absolutely. So we absolutely are going to be reworking this and implementing all of your feedback. I really appreciate that feedback. To answer a couple of points here, when naming staff-led, I am the staff. So this is kind of what most of my time is going towards, is this sort of thing, the vetting, the writing proposals, bringing all of this forward. The other reason that we do note staff-led is because often there are really tight turnarounds here. So 6 weeks is pretty standard between the actual call for proposals dropping and the deadline, and that's a very fast turnaround. So that's one of the main reasons that we highlight wanting to be nimble, is those tight turnarounds are pretty common on grants of all sizes and from all sources. So that is one of the reasons there. But yeah, primarily, we're gonna go back and rework this and bring in a lot of the comments and concerns that you've raised.
Terrific.
Thank you.
Thank you. Oh, yes, ma'am.
Sorry, walking, I'm just curious, I don't know if you discussed this in terms of the financial threshold, less than a million is staff-led, did we? Because that, I find it to be quite.
That's why we're having
Okay,
this
just wanted to make sure
dialogue.
if you highlight.
You're at the right time.
Okay.
That's why we're having this discussion right now.
I just find that to be a significant number, I would lower that threshold personally. I don't know if y'all discussed it, because to me. I said 0. Well, I would probably, it all depends on the funding. I would probably want it to be vetted, but absolutely not $1 million, less than $1 million. It could be 99.9, you never know, but that's a significant amount of money that I feel a board should have an input on. So that's just my comment, and I know this is still in works, but so my apologies for being lengthy.
Very good comment, thank you. Okay, are we all good? Y'all can continue, please.
Okay. So moving on to the next slide, this one is going to see a lot of significant changes given the feedback that we've received on the first one, making sure that we're all in line there. I will walk you through this though. This is kind of a proposed review process for these funding opportunities. Basically, 5 pretty simple steps. So I will touch on them and then again, we're going to rework it. So what we've got now is first the initial staff review. This is, of course, what I do already, regardless of the size of the proposal or what the project is or anything like that. This review is to vet the opportunity for mission alignment, financial feasibility, risk, and potential impact, all of those things that we mentioned about the return on investment and the administrative overhead, all of those things get captured under here. Based on that analysis, we put together an internal recommendation memo. For staff-led projects, the intention would be for that to go to executive leadership. And then for board-reviewed opportunities, that would go to you all. The next step is the much deeper dive. So we'll send you all of the relevant materials in advance. This would be a proposal, a budget, a list of any partner organizations, what our current partnership status is with them, what we expect as the return on investment, what we see as the administrative overhead. That return on investment could be both financial and social. There are a lot of aspects to consider there. All of those things would be included and broken down. And then of course also legal or compliance, that will all be included there as well. So those basic materials would be provided to you all, and then we would give you a formal presentation, walk through the opportunity, what our plan is, and then open it up for a very detailed Q&A and walk through the entire thing. After that, you all would have the opportunity to push it on to the full board if we feel that that's the most appropriate next step. They would all receive the same materials, receive the same information, of course. We would then ask for a board resolution on the concept, so either to approve it or approve it conditionally, so making adjustments, or defer the decision for a later date. And then upon approval, this is assuming a lot of steps have been completed. So we've determined mission alignment, we've determined that it's worth the cost associated. We have determined that it is approved by the board, and the entire thing has been put together, and crucially, the award has been awarded. If we actually receive funds, we would then come to you for a board resolution to accept the funds, which is, of course, required. And we've done that once before. That was for the opioid settlement funding. You all signed a resolution for that one. It would be the same sort of thing. And so that would be kind of the process from start to finish as we currently have it laid out. As we go back and review these, that interim process and all of those thresholds for where we want things to live, we're gonna go back and review this process as well and make sure that we're really capturing everybody's feedback and concerns. So that's what we have currently. I'd be happy to answer any specific questions on that as well or feedback there, or we can continue onward.
Onward. Well,
Okay.
yes, ma'am.
Question, comment. This is related, and I wonder if the process for grant funding is gonna be different than this process, because, for instance, that is either I'll give you an example. Let's say a clinician wanted to reach, or a staff member for a CPRIT grant. So there's an RFP out, they have to submit an application, their proposal may get funded, it may not get funded. So in what stage would it come to us? Would we approve that proposal before they can submit it, or do we approve it once it gets accepted? I'm just wondering in terms, because there's 2 different buckets, and yeah, so that's the first step. Just wondering, because each one, grant funding is different than philanthropy, so I wanted to know if we have that clear distinction.
Let me just
Please.
respond. First of all, we haven't gotten there. We haven't gotten that far. So but it's a good question. It's a good one for us to put on the list of things that we need to address and figure out how we're gonna proceed. So we'll come back to the committee if that works for everybody. And I believe Geronimo has a question.
Just a quick one around the conversation that we had around before you got here, around distinguishing federal, state, and private donations. that also reminded me too that I think it would be helpful for us as managers to get the legal definitions under the IRS for grants and donations, because they are different. But everything is here under an umbrella, so I think for a lot of folks who have not been involved with this, I think it's important to get the legal definitions that you need at some point. And they're different. Grants are different than donations, and how you handle those, and the processes may be different or very similar, but
And on that note about the legal distinctions, not to put you on the spot, David, but you had promised us to get us a little legal briefing on how this might work and definitions and so forth. I'm just wondering kind of where we're at on
Yeah, now
that.
it just got broader, apparently. And I don't do taxes, Manager Rodriguez. I definitely don't do federal tax. But yeah, we'll get you something before the next meeting.
Okay, thank you. Okay, continue, please. And I'm just gonna ask this because we're running out of time, and I'm gonna ask you to kind of speed it up, if you would, please. Maybe highlight the things that are the most important that you have on the pages that remain.
Absolutely. So moving to our next slide, our status update. We have 3 specific opportunities here. The first is the St. David's Foundation, the Pathways to Economic Stability for the Healthcare Workforce funding opportunity. Manager May had an opportunity to look over this and to discuss it with us. We submitted an application that would support clinical education programs, a lot of that in partnership with ACC. These are, of course, things that we're already working on. So that has been submitted. The Shivers Cancer Foundation, so back in 2012, we worked with Shivers and Livestrong on a regional analysis of cancer care. You all saw the demographic report. There's obviously a lot of work to do and a lot of additional analysis to be done. So we're working with Shivers to do that analysis, receive some funding from them to fund that process. And then the third is the opioid abatement funds. We have already spent about 25% of the first disbursement that we received. We just received a second disbursement of a little over $1 million. We have, the finance team has implemented a process to manage those restricted funds. We've submitted a report to the OAFC. And then beyond those required annual reports, I work closely with accounting and healthcare delivery to consistently track internally how we are releasing those fundings, that we're on track with our goals. So that's where we stand there, is that kind of ongoing process, which has been pretty successful. It's been a good stress test for how these things are going to function, and it's been great. It's worked out well. That's where we stand on that one. And then in the immediate future related to that, we expect to hear from the St. David's Foundation sometime next month, and we should have worked out a little bit more with Shivers in the next couple of weeks. Virginia's working really closely with them on that project. So that's where we stand on those. That's my very quick run through.
Very good, thank you. And then we have the other slide 23. Virginia, can you walk us through that, please?
Is that this one, this last one? Are you looking at?
Well, 35 then. I guess, I don't know which number am I using. The one about the committee packet questions.
Oh, yeah. Oh, these were the questions. We wanted to have them documented and hand them out to you so you would have them for reference. And I have them here. Hold on. And we organized them into strategic and governance, finance and policy, the data and demographics. Some of them are more thematic and guiding. So we're keeping them in mind along the way, and others were key things that we pulled out. There were things like, hey, what will the interim policy be? So you heard Kim just run through that. We also heard from you, you wanted to know more about how are some of these hospital districts showing up with their focus areas? What's the difference between the private and the hospital district style entities? So we were able to provide that in the handout. So we're gonna continue to keep a running list of all of these each time and hearken back to it every time we come before you to say, hey, these are the answers we have today. And here, these are the other things we're integrating along the way to make it very transparent, very clear, and make sure we're holding true to the
And that we're not, the main key here is that we want to make sure that your concerns as board members are not getting lost in all of the work that's being done, that we're able to still come back to them. And I believe that Manager Maram has a question.
Yeah, it's really quick. In terms of finance and policy, because I believe this will need to be in its own bulk financially, so separated from Central Health's funds. So do you have that documented somewhere? Or like the process and how financials will be assessed?
This is,
Entity too. Go ahead.
yeah, this is part of what our work right now is focused on, is working through what we want that to look like. That's the kind of review we've been doing of peer hospital districts, what these opportunities could be, how we want that to look. That's all kind of in our immediate future.
Thank you, and I'm gonna just take over this presentation, because I'm running out of time, if you don't mind. So I'm gonna ask us to skip slide 36, because I think we all kind of are there. I think that we can also skip slide 38 for purposes of today, we can all read that. But I would like you to spend a little time on slide 39, if you would, please.
These were slides that we held in the event that we got to them. And so in crafting what we put in, these were actually in our backup slides. And so we are not prepared to talk about the best of. I think this was a first
fine.
draft that we took.
Okay.
Manager May, it's not a bad first draft, but I would say that we know
It's always a good first start.
Hey, it's a good first start, and I think it's a little early. We wanted to do it so it was there, and it also was directly related to one of your questions.
And-
And so for this purpose, we wanted to have it there for you.
Excellent. And then the public charity versus private foundations, again, like you said, you may not be ready to speak to it yet, but it's letting us know in the direction that you're going, and it helps us as a committee also see where we're going, and also prepares us for any further fundamental questions or fundamental issues that need to be established as we move forward. So if you're not prepared to speak to them, that's totally understandable.
We
But
wanted to have a notation that it was addressed, and in particular for that one, Manager May, we would definitely need the support of our colleagues, our counselor colleagues, to make sure we're thinking about that correctly. So we will sync up, our plan is to sync up with them and see if we want to do a broader session. You and I didn't get to discuss this, but we could do a broader session just focused on the legal definitions and structures, all in one.
came up.
Yeah.
Yes, ma'am. We have one question from our chair.
Just a quick comment on your slide that says best of structure. I know you're still working on it. You might add a row for accountability to the board. So, okay.
Yep. Thank you.
Thank you. And then, I'm gonna move us over, I know it's backup stuff, but you've also included philanthropic pathways for Central Health, strategies, models, and insights. Can you just tell us, just very briefly, a little bit about this? And the importance for us on this, with respect to that document?
You got it. So there are three components to it. One really runs through what the top 10 entities in our state consider as focus areas and how they're structured. And so we made it a point to both include the hospital districts as well as entities that are affiliated with private systems. I think that's a key point, especially when we have folks like St. David's right here in our backyard, right? And so we wanted to make sure we had that. And then we delved into, you saw me present, the last slide I presented was about the way we could approach what we would focus on. Are we new program, old program, capital, what are we? And so the second component of that document you're referring to, Manager May, has a lot more information and what that looks like and what the benefits are and what the drawbacks are. So it did a little bit of analysis there. And then the final thing we included is how are we viewing approaches of a private foundation, hospital foundation such as St. David's versus someone like Parkland Health that is a hospital district. So there's some distinctions there that I think can be really helpful to just level set for all of us so we're aligned in how we perceive those things. So those were the three components of that report.
Thank you. And then the last document that you have, you can just bring us up to speed on that one, Central Health Philanthropic Initiative.
Yes, this is a document that was, I believe, submitted by Manager Valadez, and we had some emails back and forth and said, you know what, the best thing is to make sure that Manager Valadez, we can honor your work and included in the packet alongside some of the other handouts. And so we ask you, managers, to please review that and follow up with us on any questions that you have. But again, thank you, Manager Valadez, for giving that review to us and including it in the handouts.
Thank you.
Appreciate it.
While we don't have a next scheduled board meeting, I think it's imperative that we keep the work going and we keep ourselves in this momentum. That being said, we also know we have summer vacations popping up. They're gonna start creeping up. But what I'm gonna recommend, and of course, it's ultimately y'all's decision here as committee members, but that we meet one more time in June, before vacation schedules really start going crazy on us. And if y'all would be willing to meet in June, at a time that we don't have strategic planning meetings, so that we're not conflicting with strategic planning. And we'd have to work with staff on that. But if you're willing to do that, let me recommend that we meet in June. Yes, ma'am.
Maram, I know you usually leave in the summer. Is it July that you leave?
I'm leaving end of June,
The end of June?
yes.
So,
Are you making the meeting in June for the board?
Yes and no, if that makes any sense.
You're doing virtual?
I haven't really decided, but I know
Okay.
that we can talk offline,
Okay.
but I will,
Let's plan, and we can always move things around. We'll go ahead and plan, and that way we can keep our agenda going. And then next month after that meeting, we'll figure out what our respite period will be for the summer, when we all take a hiatus. How about that? So with that, I'd love to take a motion to adjourn. Second? It's been moved in second. All those in favor, please signify by saying aye. Aye. Thank you. I'm sorry, Maram, I took a little bit of your time. Do the musical chairs.
because we want to hopefully end this meeting early. Apparently, there might be some bad weather, and I want everyone to get home safely. So let me know, Edwin, when we're ready. We are? Okay, perfect. So good afternoon, everyone. It is May 28th, and it's 4:15 p.m. And as a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, do we have any members online? Is Pat online? He is? Okay, thank you. So we do not have any members online currently, and I would like to announce that in order to make it more accessible to community members, we will hold public communication for the Budget and Finance Committee and Board of Managers meeting at a time certain at 5:30 p.m. unless a member of the public wishes to make a comment on a specific item on the Budget and Finance Committee. Do we have anyone signed up to speak?
We have one member of the public signed up to speak.
Okay. Well, can you call their name and?
Yes, we have Walter Morrow, who should be here with us in person.
Yes.
Walter. Thank you so much. I'll read off this evening's public communication guidelines. When called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number after your introduction. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. Thank you so much for being here, Walter. You have 3 minutes.
Welcome.
Great. I'm Walter Moreau, the Director at Foundation Communities. Thank you for the chance to speak. One of our passions and programs at Foundation Communities is to help people get health insurance. I never thought that was controversial. Like, it's so important for our community that people access health insurance. But we're under a lot of pressure right now. The enrollment period for the marketplace is going to be cut to 6 weeks. The enhanced premium tax credits that reduce the cost of the premiums is going to be probably expired. And there's worse stuff in the House bill that's working its way through Congress. We had a federal Navigator contract. It was $2.4 million this past year to help enroll folks. So we built a $3 million program budget, did fundraising for about $600,000, and we enrolled about 6,000 people this year. Our specialty is folks who have complex medical cases, folks with up and down incomes like musicians. We love this program. We had 100 volunteers that worked really, really hard to get that 6,000. And really, over the last 12 years, we've consistently, all through all the ups and downs of the marketplace, we've enrolled 4,000 to 6,000 people a year. We can't do that this year, which is really, I should say, 5 months from now, on a $600,000 budget. We've had great conversations with your staff, with John and with Kit, about an investment from Central Health on terms and at a level that would really help us maintain a robust program. We know you can't replace $2.4 million, but we're hopeful you can replace a lot of that, and we'll double our volunteers to 200, and our goal is to continue to have a really big program. It's a unique program. There's no other organization in Central Texas at this scale, with this level of experience, with this track record, with this level of community trust. We're going to run this program on whatever shoestring operation we have to, but if we want to keep it at that 4,000 to 6,000 level, we really need your support. So I'm hopeful staff will come back to Budget Finance or to the board in the next 30, 60 days with asking for your approval. we're going to shrink our staffing to, and we need to make some big decisions here in the next 60 days to gear up for the program November 1st.
Well, thank you so much, Walter, for addressing it. I know we have an agenda item number 7, legislative update, so I think I can ask a question. David? Can I ask him? Based on, because the budget, just want to make sure, because you can only communicate directly with the public unless it's posted. So you mentioned that you're in communication with our staff, and I know that staff have mentioned to me in a meeting that they're working on something, and you haven't narrowed down the amount, my understanding. Is that correct? So would we know by June what that amount will be? So if you can bring that up for us to take consideration, and I am very grateful for all the work that you have done and for your staff, and unfortunately, we're in this environment, and we will do our best. So thank you, Chair.
I just want to say thank you for coming to speak with us and appreciate the work that our staff is doing with you. It's helpful for us to understand the type of program that you've shared with us and the financial needs that you have. So we'll look forward to hearing from the staff in June, and hopefully we'll get to a point where we can keep this level of service.
Awesome.
Thank you.
Thank you.
Thank you so much, appreciate it. Do we have anyone else signed up to
This
speak?
concludes this evening's public communication.
Okay, thank you. So, really quickly, members, speaking of access to care, over the weekend, I had a community member reach out to me about a resident who unfortunately found out they had cancer, terminal type cancer from the ER, and they were admitted and they found they had this cancer and was trying to seek what are options and services available for this particular individual who happens to have an aggressive form of cancer who needs immediate treatment. So how can we help? So what brought to my attention is like, this is an uninsured individual. If he was insured, this cancer would have been caught earlier. They would have had the screening. They would have been, probably their outcomes, prognosis would have been different. And that's why our work is very critical to ensure individuals have access to care and are early screened. For preventative health, it could be even for, not just for cancer, for other chronic morbidities. So it's really important for us to have coverage, but unfortunately, there are a lot of variables that really determine that outcome. And as a board member, I'm truly humbled and honored to do this work to ensure that individuals can receive the care, the access to the care they need. So, Mr. Walter, we will try our best to ensure individuals maintain that health coverage. Now, members, as we will now proceed with the committee agenda, we will not be taking up agenda item 8 tonight. So that is the only item that we will not be discussing. I will move on to agenda item number 1, approve the minutes of the April 23rd and May 15th, 2025 Budget and Finance Committee meetings. I move that the committee approve the minutes of the April 23rd and May 15th, 2025 Budget and Finance Committee meetings. Do I have a second? Manager May seconds.
I have a correction.
Yes, what is your correction?
The correction is that it didn't include me as being present at the last meeting, yet I voted. If you look at the minutes at the top, those present do not include Cynthia, manager Valadez. If that could
Thank
be
you for
corrected.
pointing that out. Can you please make that correction? So I will amend the motion to include that correction. Any other questions, discussions on this item? I see none. All in favor?
Aye.
Motion carries. Now, agenda item number 2, receive the April 2025 financial statements for community care health centers. Jocelyn will be presenting, and Hello, doctor. Good to have you.
Good afternoon, everyone. In the interest of time, I'll keep this really succinct for you all, so I'm not going to cover in detail each of the slides. If you go to the next slide, I do want to point out that April was a very positive operating month for us. We had a surplus of about 4.2 million or 4.8 million, and that was driven by two major pieces. We were able to work with Central Health on an infusion of 2.8 million in revenue to offset operational losses for several of our locations. And we closed out a liability we'd been carrying on the books of about 2.8 million. We are still expecting ongoing monthly operations May forward, but this was a great way of helping close that financial gap. Next slide, please. And that infusion of cash and revenue brought our cash balance up by about 5.3 million, bringing about 39 days cash on hand. So in a much stronger financial position in April. Next slide, please. And encounters are still under budget, but we are onboarding 15 providers over the summer. So that is really great progress. We also have the contract starting in September for our convenient care locations and are onboarding about 9 providers for those locations as well. Next slide, please. So while many of the pressures continue, we are moving forward with increasing access and moving forward with other strategic activities and working very hard to align our financials and our expenses and our revenue. Do you have any questions regarding the April financial report?
No, well, I don't have, I'm looking up, sorry, correcting myself. I remember that you're going through a downward, so there's a shortfall. Have you estimated that shortfall for fiscal year 25?
We are working on that right now. Now that we've got April firmed up, we're looking ahead to see what the rest of the year is going to hold. And I will have that number shortly. We're just doing the rest of the projections now. We are expecting about a $1.2 to $1.5 million operating loss for the next 5 months. So it's probably going to be around $7 million, $8 million by the time we're done.
So you'll have a better estimate by next month?
Yes. Mm-hmm. Well, we will have one probably within the next couple weeks.
And would that request be for next month?
Oh, yes, I'm sorry.
Just
So
wondered to
I've been
know in
working
terms of
with-
timeline.
Yes, I've been working with Jeff and John on really looking at maybe June or July for bringing back more firm numbers on where we think the year is going to end to the Finance Committee.
Okay, and you said in terms of hiring staff,
Mm-hmm.
so I'm just out of curiosity, those staff are clinicians?
Yes.
Primary care or
Primary care, internal medicine.
Yeah, those are largely our primary care base. So that's pediatrics, family medicine, internal medicine. We also have some of our convenient care staff that occasionally are emergency medicine trained, but that's our primary care workforce.
And okay, maybe I'll ask this question offline. So thank you for that. I'm going to open it to the floor. Any members have any questions? I see none.
Thank you.
Thank you. So there is no motion for this item. Appreciate it, and we'll see you next month, and we'll work with the team about your request. Thank you. Now moving on to agenda item number 3, receive the April 2025 financial statements for Central Health, including capital projects. Nikki Riley will be presenting. Hello.
Hi. Good afternoon, Nikki Riley, Deputy CFO. The packet for the April financial statements is all in there, and I believe the last page is the capital update. There's nothing that happened that was remarkable in April. I did, however, add some items to the direct services that was asked for. By service line, it is on slide 8.
Just a second. Can you make that a little bit bigger?
She said slide 8.
It's called Direct Services.
It's 30.
Oh, okay, oh, yeah.
I've added, you wanted to see FTEs that are in that service line, budgeted FTEs, patient encounters. I have those in here for April, but then also for April year-to-date. The service line start date. And then we also, the co-hires are the providers that we have co-hired with UT. And I think we have a couple PRNs as well that are not listed in here.
So, thanks for the slide. This is new, and I think members will need to take a deep dive into this slide. But a couple things that stick out to me. Can you break the patient encounters between unique patients each month?
That's a question that I'll need to ask for the data
Because it would
analyst
be
team.
helpful to know, because unique patients versus visits. And when you said the co-hires, and if maybe a legend will be helpful in the future, just for us to understand who are the co-hires. This is the UT Central Health?
Yes, they're co-hired with UT, yes.
And you mentioned something budgeted. Do we have unbudgeted hires that we?
No.
And for each service line, these positions that we have, because I see some of them who are not seeing patients. So is every clinician that we have hired are seeing patients, or do we have clinicians who have not seen patients yet?
There's only one that I know of. It's a .1 provider for rheumatology that we just hired. And they are helping us get that set up.
Okay. Well, any members have any questions? Manager Valdez?
And just a further clarification for your comment on the UT hires. If we can, she asked for that to be a legend. I'd like to see the separate number.
Separate number.
What do you mean by a number?
Okay, so if we have two medical providers that are providing rheumatology services, and they are both UT, I want to know that they're both UT and not Central Health.
All
Who's funding it?
co-hires, all co-hires are not Central Health employees. This is contract labor.
Okay.
Yeah. So,
I guess what I was just a bit concerned about, or wanted more clarification on, is I knew that we were giving them $35 million a year. Now I understand we're giving them several other contracts. And if there are additional contracts to UT over and above the 35 million, I want to know what we're giving them money for.
These are just for providers to be able to see some of our patients that we do
No.
not have providers for.
And so in that case, which ones are they? Which lines of service?
here they are, manager.
Like-
I know that it's very small.
These are different specialties.
Right, right, right. But these are not all UT. I think I'm having a difficulty explaining myself. So.
John, do you want to?
The difference between between UT
Yes, ma'am.
providing the services, and
Can-
thank you
can we
for
go back
understanding
to
me,
the
Jonathan.
direct, yeah, so this slide, if you'll, there's a lot of information we're trying to condense on one slide. Some of this may lend itself to a separate, more in-depth update to the board that we can answer a lot of these questions. But just to clarify what Nikki was saying earlier, the actual versus budget FTEs, those two columns in the center of the slide, those are our actual employees. Those are inclusive of physicians, other providers, our nurses, medical assistants that work in each of these service lines, And then on the very far right-hand side, those are the co-hires. The co-hires are physicians only, and that the 0.8, that could be more than one physical person. It's a 0.8 effort that is usually combined of more than one actual person that's rotating through. Does that make sense, Manager Valadez? Okay.
So in gastroenterology and nephrology, diagnostician and medical respirant.
So,
Yes, so each of those has a UT physician co-hire working in the space. It doesn't mean that we only have co-hires working in that space, but in some cases, UT's been able to recruit where we have not.
for the co-hires, I know this is amount effort. Could you like break it down to how many?
Oh, sure, yeah. I mean, we're happy to come back and provide that information.
Okay, and again, members, if you have any, this is the first time we're having this slide. If you have any questions or comments, please let us know. Yes, Manager Jones?
A follow-up on Manager Valadez's question. So are we saying that we are able to ascertain the number of UT hires that we have in each of these categories at some point?
For UT hires working in the central health environment, those are by name specific people that we go through a co-recruitment process and hire jointly with UT. Now, there are a lot of other UT physicians that are working in the Ascension environment, in the community care environment. This is just Central Health Direct Practice Clinics. So Rosewood, Zaragoza, the Capitol Plaza, those clinics.
Okay, I think it'd be helpful to, and I think this is where you may be going, to get a number of providers that we're actually getting from medical school and sort of update that every now and then so we can see if there's improvements.
More broadly, not just the central health environment? Is that
Yes.
what you mean? Okay, understood.
You can separate them out.
Okay, and I have a question in terms of the co-hires and what we have budgeted. So for the budget, did you budget for those co-hires, or this budget was simply just for central health
So we
hires?
budgeted for the position and the salary required for the recruitment of the position, and then leave ourselves in the budget, the flexibility in whether that's a direct hire, whether that's a co-hire through UT. It could be in some other instances that we need to contract with a private practice in town to provide some capacity in our clinics. So we budget for the capacity of the physician that we intend to recruit, and then we try to pursue that recruitment through a lot of different avenues.
Okay, thank you. Any further questions? Okay, no, I don't see any further questions on this. So if you can just break it down by unique patient
And to be clear,
encounters.
you want that added to this slide. You want
Yeah,
unique,
but this
unique
is-
patients on this slide.
Yeah, if you can probably make it a little bit more easy to read, because it's a lot of information condensed, maybe breaking it to 2 slides or however you want.
Is there anything we've put on this slide that you don't want to see on a regular basis? Since this is the first time you're looking at it, we're happy to make adjustments.
I think this is really helpful information. I like the percent budget used, the number of FTEs, the patient numbers. I think this is all information that we've asked for in the past, and we just want to expand on it.
Understood.
Thank you.
Thank you.
Anything further, Nikki? Manager Jones?
I'd just like to make a comment.
Yes.
In light of our discussion previous, I think it would be very helpful to consider foundations or other organizations that could help in terms of supporting our staff, our medical staff. When we start looking at those kinds of things, these type of issues here, this kind of data here will help us to be able to justify or to make the case that yes, we need foundation funding to help us underwrite some of the efforts we have. And I think this kind of data will help us in doing that. I just want to make sure. If that makes sense, I'll explain later if you didn't understand.
Thank you, Manager Jones. Dr. Brinson, do you have your microphone on? Speak.
Can I ask a question about page 31? Is that okay? Yeah. Okay, so I noticed that some of our service lines are really bumping up against our budget presently. and that we'll be over budget pretty soon. Does that mean we will be expanding these specialty lines?
Is that the specialty care slide?
It is the specialty care slide.
Those are on contract. And so they can only go up to the contract. And then John and executives look at those contracts to see if they want to increase those.
Pretty regularly, we review these as we receive claims. Our team projects an end-of-year estimate. And some of these are areas that in this year's budget were intentionally areas that we were trying to expand access to. Oral surgery is probably a good example. ENT, those are services where we had single provider partners in the community providing those services, or at least the vast majority of those services to our patients. And so in the budget, we did anticipate adding additional providers to the network. I think some of these are really good examples, though, of where we don't have a great picture of what the need is until we create the supply. And as we create additional access to services, we start to generate a lot more referrals from our primary care providers, and some of which, as you can see here, have exceeded our expectations. But we do have an ability to amend those contracts to accommodate the additional volume, as long as we're not going to exceed this overall specialty care budget. If we're going to exceed this overall budget, we're going to have to come back here to budget and finance.
Okay, thank you.
Yes, ma'am.
Can I ask a follow-up?
Yes, Chair.
Just a quick follow-up. So 30 and 31, how do I understand these together? In other words, just for example, the gastroenterology line under direct services, that is in addition to the gastroenterology line under specialty care?
That's correct.
Okay, thank you.
Yeah, those are our network providers. That would include Community Care's GI service, and then we have, I think, 3 different private practice GI providers in town, as well as the surgery center expenses associated with endoscopy.
Manager Valdez.
Thank you for expanding on that, because what I would like to look at eventually is to, if we have all the service lines, whether it be primary or specialty care, so that we can, in this one area, we will know this is how much money we spent, how much money we may need for forecasting as trends develop. And especially since we're talking about podiatry and some of these others where you're at 80% already of the spend, and we're 5 months into the fiscal year or 6 months into the fiscal year.
I think that's a great point, Manager Valdez, and I should point out that the dollar amounts you're seeing here are direct expenditures from Central Health. This does not include the services that are being provided by Ascension in their hospitals or other facilities. That's not a direct payment methodology. So this is all expanded services on top of that.
That would be good information for us to have as we look at budgets. Thank you.
And a question, right now with CUC, are they referring their patients to Central Health Specialists?
Great question, and that's an active body of work. Kim is actually helping us lead a joint process with Community Care, where we've got our referral teams working together to make sure that we're getting patients to the place where they can seek care the fastest, as long as there's not another overriding care continuity type of factor that would dictate that a patient needs to go to a specific place. But when we have a service that at Central Health that Community Care also has, or that we have in a network contracted provider, that's part of the work that our referral management teams are doing, is triaging that referral, making sure that they're getting to the provider with the right expertise, and they're getting there to wherever we can get that patient served the fastest. Does that answer your question?
Yeah, but I'm like thinking about if we're expanding services and we're referring them out, I understand the time. So do we have even a longer wait time, or like what are the challenges that you are
Depends.
encountering?
Specialty by specialty. GI is a great example where despite Ascension services, and Ascension's working with UT for GI as well, we have direct practice services here at Central Health. Community Care has GI, and we've got a number of providers, and we still have a 5 to 6 month wait list for patients regardless of the environment today for GI services. And so that continues to be one of our top priorities in terms of specialty care service lines to expand access. And we won't really have a perfect picture of what that patient demand is for services until we're able to incrementally add that provider capacity and make sure that that service is more reliably available for our PCPs to refer into.
Okay, really quickly, Manager Valdez, so we can,
No.
go ahead.
Oh, okay. Just quickly, thank you for bringing that also up, Jonathan. So that in my head makes me think about it, because I can remember when we, at one point in time, were talking about how we had some of our appointments were not being made, people are not showing up, blah, blah, blah. So that continued, we're losing money that way. Yet we're paying extra for out-of-network, I want to call so-called, out-of-central health services to those private providers. This would be a way, I would think, of seeing how we can kind of strategize on the flow of providing services and whether or not we really need to contract out for these out-of-central health services. And we need our community to understand the need to use our services. That's what we're paying for. And
You're hitting on some of my favorite topics.
Okay.
I mean, this is a huge balancing act. We
Yeah.
try to take advantage of providers in the community that provide high-quality care and want to take care of our patients. Our patients often have challenges that a commercial population wouldn't have, whether it's transportation, kind of, what's your point, no-show rates that creep up. In most of our contracted environments, not all, but most of our contracted environments, we only pay for a service that takes place.
That's
So
right.
that no-show risk is on the providers
That's right.
versus in our environment, we own that risk, but we also have the ability to mitigate it with transportation assistance, with appointment reminders, with being more proactive about those kinds of things.
Thank you, John. Thank you, Manager
Those are good
Valdez.
reports to us.
Dr.
Thank you.
Martin.
Thank you. Thank you for the presentation. My experience with this population was that no-show rates were extremely high. And I granted that in the private sector, it represents a problem for, I would argue, for retention of these people, because they're like, people won't show up and they're being paid to not. So they don't show up, they're not being paid. But maybe perhaps, I don't know how much effort or control we have over community care or our clinics about simply overbooking.
Yes.
If that's a standard practice, because I think the no-show rate in residency programs is about 40%. It's very, very high.
And I can tell you that, we have no-show rates that we can bring to the board. We have that by service line, that's other information that we can bring. I don't want to quote anything because I'm sure I'll get it wrong, but we've got much lower than standard no-show rates in our clinics because of that proactive approach that our teams are taking.
Chair, could I make a suggestion?
Yes.
Around
Could
20%
I
right
make,
now.
could I make a suggestion? This is a really, really important topic, and I'm hoping that our medical committee might be willing to take that up and really get into some detail with you guys to really understand how referrals working. Dr. Martin chairs that. And of course, it's open to all board members to attend, of course, but I think this is a really important topic, and if you're open to that, that'd be a good time to talk about it.
I think it's an issue really truly in regards to for efficiency issues because of money spent, and I
Yeah.
think that's very important.
Are you okay with that?
Yeah, absolutely.
Okay.
So,
Okay, well then we could,
so we'll take this
Defer that.
to further conversation in the future, near future, so.
That's where we're trying to strike the right balance of what information we embed in the financial statements for you all. and
Thank you, this is
what we take
helpful,
into
and we'll
detail.
we'll have multiple iterations, but thank you, Nikki, appreciate you, thank you, John, thank you, everyone. Yes.
I have one more item, and I wasn't able to get it into the packet, so I'm gonna give you a handout. But this is something that is in the financial order that Travis County asked for that we will be presenting on June 12th. It is the consulting, legislative, and legal services expenditures for this year. And we didn't want to present it to them without presenting it to the board first. So, I'm just gonna hand that out. If you have any questions, thank you.
Perhaps in the future, that if we have a policy in place to when we go out for outside counsel, so we would like to have that, to know what is the central health policy on that end. So Yeah, so especially that they, the commissioners have asked for this information, so we would like to know, when does Central Health seek outside counsel, on what basis? So I just wanted to know, do we exhaust our internal resources and then seek out outside counsel, or do we immediately go to outside counsel? So whatever your policy is, if you can bring it back to us, maybe Perla, you have something, so if at our next meeting, if you can provide us something. So I am gonna close this item because of time. Are you all in agreement with that request? Okay, thank you. So, thank you, Nikki. Now, moving on to our next item, which was discussed at our last meeting. And I should be more organized. Oh, here it is, sorry. Item number 4, receive and discuss and take appropriate action on amendments to the Colony Park capital budget. Stephanie McDonald, are you here? Oh, there you are.
Managers, today we are requesting your action and a recommendation to the full board that we amend the capital program budget for the Colony Park Health and Wellness Center to the $37,296,704.48. If you will notice, what we were planning for in 2019 has dramatically increased based on the data and the need in the community. I think this overall budget is in line with the construction costs that we have seen similarly at Del Valle and other projects. And with that, I recommend and request action. Thank you.
Thank you. Can I have a motion first before? Manager Jones? The motion is. Can I second it? Let him read it first.
I move that the committee recommends that the board approve the amendment to the capital budget for the Colony Park project as recommended by staff.
Thank you, and a second by Manager Valadez. If I can just possibly, and I think we discussed it previously, in the future, whenever there's changes to the scope of projects that involves a financial, sorry, what? Okay, yeah, so but in the future, if you're gonna change any scopes to new projects that will have a financial impact, just to let us know ahead of time.
And I believe we came to the board previously with that change.
Yeah, I know, just a reminder.
Absolutely.
Nothing
Okay.
else.
No, absolutely.
Thank you. Any questions on this motion? All in favor? The motion carries. Thank you so much.
Thank you.
Now, moving on to agenda item number 5. Discuss and take appropriate action on presentation regarding fiscal year 2026 proposed driving forces. Anissa Kendall will be presenting.
Is this, okay, do we need a presentation? I mean, this
I
is
don't
the same
think we
thing we've
can
had
have
for three times now.
I think it's just a slide.
Okay.
Yeah, that's what. So I think you just have, can you just show us the driving forces?
There it is.
So, if I may, members, y'all had an opportunity to review these driving forces and provide input. And at this time, I think majority of voices have been accounted for. And we are ready to vote on this. And Chair Kitchen has a comment.
I'll just make a motion.
Oh, go ahead.
I move that the Budget and Finance Committee recommend approval of the driving forces to the board,
As recommended by staff.
as recommended by staff.
Do I have a second?
Second.
Manager Valadez actually had her finger raised. I'm sorry. Sorry, Maria, because it was. Okay, any comments, any questions? I see none. All in favor?
Aye.
Motion passes. So, see?
Thank you.
Your job was well done. Thank you, Anissa. Appreciate it. Now we are gonna be going into closed session. Where I am gonna announce that we are gonna go to closed session to discuss agenda items number 6, Do I have to read it?
Actually, I believe that for item 6, the majority of it is going to be an open. And
Is
that
it?
the remainder, if there was a question, we were going to go into closed session. That's why it says if needed on the closed.
Okay.
Monica, or y'all, is that correct? Yeah.
So,
the majority- it's
agenda
planned
item-
to be in open.
But we're gonna go for 7 and
7,
close.
yes.
Okay, perfect. Unless we need to go for 6. So I am gonna take item agenda number 6, receive, discuss, and take appropriate action on an update on the implementation of the Service Delivery Strategic Plan, Health Equity Plan. Is Jeff here tonight? Okay, Jeff is not. We're gonna have John Morgan, Alan Scholza, and Monica Crawley will be presenting. And I know you're all gonna present this information, this type of evaluation for the first time, and there's gonna be a lot of questions. So if possible, if we can make it a little bit, condense the presentation to allow members to talk, to ask, to entertain their questions because of the weather conditions. So, just wanna take that into account.
And there is a lot of material here, so if we have to bring it back to
So,
make sure we
yeah,
cover it all,
maybe we
can.
can do that, split it. Perhaps we can split it. So, Monica, if you can find appropriate placeholder where we can pause and reconvene next month.
It's all on you, Monica.
Absolutely, and I'm gonna let John and Alan kind of arm wrestle over that one, but we will, because I think John's turn starts at about slide 15, and so he would like to recommend that we split it at slide 15. That's probably not where we're going today, but,
Okay, so if we can do that, so if you want to take a look at it really quickly and decide how to quickly between you three, where you're gonna end and stop. You're good? Okay, so, please proceed.
yeah, no, I actually think on slide 14 or 15, let's see where we get to, but we might stop at about slide 15 this time. So thank you so much. Budget and Finance Committee meeting, Dr. Musayev. This afternoon, we're providing an update on our progress in implementing the Healthcare Equity Strategic Plan. This is going to include a refresher on the plan and how we came to the plan for members of the Budget and Finance Committee and Board of Managers who weren't on the board at the time, and the estimated financial commitments for addressing the community needs and the initiatives at the time of adoption, an updated timeline and high-level key performance indicators that we brought to the board in April of 2024 related to this plan, and also very detailed information by community need, project, and year. This, like we said, there is a lot of detail in this presentation. We'd like it to be a discussion with board managers, members, so it's not one of those presentations where we'd like to plow through it and then have you all hold questions. It's very dense, and so Dr. Musayev, if it's okay, if there's questions that come up and you'd entertain them, then we're open to that as well.
Yeah, absolutely. As I mentioned earlier, and during our meetings, this is a very important topic for everyone to discuss, especially the significant investment that we have invested in. And I think primarily, if I want to tee it up, this is really about outcomes. What are we getting from our plan? Is it worth the investment? So think about, this is more numbers and outcome based versus more of the whole strategy and vision of the plan. If that makes, so that's how we would like this to proceed, the information presented for this committee.
Absolutely, and we will be bringing back an update of the key performance indicators from last year next month. So we had already anticipated needing to bring this presentation back, even if we had gotten through this entire presentation today. Next slide, please. So this is just for new members of the Board of Managers, and we can go into more detail during kind of the onboarding process. But in the fall of 2023, the Central Health Board of Managers adopted this service delivery strategic plan, or the healthcare equity plan strategic plan, following a 2-year process that included community engagement, stakeholder engagement, engagement between the Board of Managers and staff, collaboration on this plan, and it was data-driven. It focused on a community health needs assessment of all of the healthcare needs of the community for people under 200% of the federal poverty level, and identified gaps and priorities related to meeting those identified community needs. Next slide. Because these presentations are kind of documents that are part of our permanent record, we include this slide in any presentation about the healthcare equity plan. You've seen this a lot. We're not going to belabor the point tonight, but the work that we are talking about tonight is the work to address the significant and moderate needs that were identified in every area of our healthcare system. Next slide, please. You also have seen the next 2 slides quite a bit before. Jeff usually talks about them. The next 2 slides include information that was the estimated cost of addressing each community need with key initiatives by fiscal year over the 7-year part of the plan. We're not going to walk through these because these were the estimates at the time, but if you have questions when you're looking at what comes next relative to the past, then yeah, absolutely, please bring them up.
So those are estimates. Do we have current expenditures?
That is what's coming. Yes,
Okay.
absolutely. So we wanted you guys to have the baseline so that you could always go back and look at, this is what we expected, and we estimated at the time that the board adopted the plan, and then compare that with, and I'm a paper person, so for me, I have to pull this apart and then hold it next to the slides to come so that, you know, I can really see how these work together. Next slide, please. Well, back one. Yes, this one, if you just, the key point on this is at the bottom. It is about, and these are very small numbers, there's about a 700 million total operating expense estimated from 2024 through fiscal year 30, with an additional 128 million in capital. So it was an over 800 million estimate for the healthcare equity plan work over the 7-year period, and that was over and above the baseline expenditures every year for our network contracts with organizations like Community Care, Integral Care, and our other network providers and administrative cost. Next slide, please. Thank you. This slide is something that will be handy. We will come back to it next week after we've gone through the detailed slides. But this slide is an update of the major project timelines and go lives. If you look, the dark blue represents kind of planning, executing, and scaling. The dark green boxes relate to a number on the left-hand side, and those reflect when the projects or initiative actually launched or went live. So like, for example, the Rosewood Zaragoza Clinic launched in Q4 of 2024, and it's been scaling since, and we anticipate it to be kind of fully operational and up and running by the end of 2026. If you look at the light green, and where that light green exists, that reflects an accelerated or shifted timeline. If you look at the kind of bright blue, like number 17 in the middle of the page, which is expansion of services, including the sobering center, then that's an expansion or a scaling of services that already exist. And then if you look at kind of the bright pink boxes, like number 11, the East Clinic, then that's kind of an emerging opportunity or a new investment that we hadn't anticipated at the time.
So I just want to also remind members, whenever they have an accelerated program, It will have a, so if you can
Yes.
elaborate more, a compounding financial impact. So just be aware of that. Dr. Martin?
Maybe I missed this, I'm sorry. What is the number, say an RZ clinic, what does the number 2 represent?
So the number 2 represents where in the initial kind of list of initiatives, we had, there was an earlier version of this timeline that only included maybe like 10 or 15 projects that were initial projects, and those numbers reflect the initial numbers, and then we've added on, and based on where things actually happened in the timeline, you know, it doesn't go 1 to 17.
Okay, thanks.
Oh, yes, yeah, we can bring the original back, so you have that as a comparison.
So if you can also have a legend also for those numbers, it will be helpful.
Yes. And if you look at the far left-hand side, just for now, there should be a number that goes with each kind of listed major project.
Yeah,
So,
so
yeah.
next time, just attach it so we can reference to it.
Yes.
Thank you.
Next slide, please. So this is also a high-level slide. Jeff will be able to speak to this in more detail when he's back with us. He would normally speak to this slide, but it really just shows, starting in October of 2023, at the time of adoption through April of 2025, we are adding on average about 16 new FTEs every month. The bulk of those FTEs have been in direct service delivery, with additional FTEs added in healthcare delivery ops, and then a smaller percentage of FTEs added on the administrative side.
If I could just go back to Manager Musaitiv's comment, when we have an initiative that's either delayed or that's moved up, that's really a one-time additional expense or a one-time savings. If we add something that's completely new or grow something at a scale that was not anticipated, that's going to be an additional ongoing cost that adds up every year going forward outside of what was budgeted in the plan. Does that make sense? Okay, thank you.
Manager Valdez?
Just a quick question. When we're talking about like program area, operations and support or administrative costs, is there a percentage that we're keeping to within each line?
So I think from the finance
20%?
team, she says it's way below
Well,
20%.
I want, is it way below 19 or is it way below like 10? That's, at some point in time, I'd like to know that.
Yeah, no, and we.
Not right
we can
now,
ask.
but
Yeah, absolutely.
thank you.
Percentage of admin is what you're.
The
Correct.
admin percentage of the overall.
Well,
Yes,
either,
absolutely.
it would also be operations. It could, administrative for sure, but operations. Especially as we're looking at budgets.
Absolutely, and I think Jeff would likely be able to come close to answering that because that's his, bread and butter.
So,
Do-
yes, go
Okay,
ahead,
so,
Manager Rodriguez.
How do you report out, like I noticed how you have the FY 2025 budgeted and you've done this FTE trends by program. Do you report out, I'm just thinking in the back of my head about workforce challenges, like do you actually, are these actual FTEs or are these proposed, I know there's the budgeted number. In other words, did you meet whatever the FTE, yeah.
So those are the last two columns of the table to the right. That'll show you where we were as of the end of April. Against the last column is the total budgeted for this fiscal year. So not all areas we've been able to fill, and not all were intended to be filled earlier in the year. If you think about the clinical education center and the medical respite facility that's going to open in July, a lot of those positions are just now being posted. We didn't want to have those folks onboarded in the first part of the year and then not open services until later. So I think largely we have probably had more success in being able to fill positions than we anticipated. There are some areas where we simply have not been able to recruit. And we talk about those in several different settings, but neurology is a great example where we have not been able to recruit a neurologist, so we have not filled that entire team because we don't, again, want, nurses and medical assistants sitting around if we don't have a provider to see patients.
Yeah.
So there are some areas that are challenges. Mental health and psychiatry is another good example that are just challenging all around.
Got it.
Does that help answer your question?
Yeah, it does. It's about timing and about the different recruitment and the detail. So, got it.
For this slide, can you expand it further? What I mean by expanding, like, which areas, service lines are you looking to hire these direct employee, direct healthcare services for? So I just want more expansion. This is a very high level. I think it will be helpful to really go into the weeds of these programs and which service lines are you trying to fill in, where the gaps are to identify. So I think.
Drill down.
Yes.
And for our direct practice areas, that was part of the detail that we included in the monthly financial statements, is it shows.
So would it mirror that?
It's very close. I will always give the caveat that it's gonna depend on what day this was finalized versus what day that was finalized, but they're very close. And it would show you the budgeted positions and the ones that had been filled by service line.
I think that would be helpful for us to have those lines, because I'm thinking about that slide that was presented to us today. Okay, thank you.
Next slide. Oh, this one, thank you. So these are the areas of, and it's very lightly shaded, so I apologize because the shading is harder to see than it was originally. These are the healthcare equity plan KPIs that were presented to the Board of Managers in April of 2024, and that were developed by the Guidehouse, developed with the board and staff and the Guidehouse team that worked on the healthcare equity plan. We were able to track metrics on 9 key performance indicators that across these areas that provided valuable insights into the effectiveness of direct practice, system growth, and under which that we could actually collect data and report out on it and refresh it with a level of confidence and accuracy. There were some areas that we didn't necessarily have data at the time, so we did not highlight it, such as the throughput metrics moving across the entire system, because we don't have data across the entire system. But we did have 9 areas, 9 KPIs, including access metrics, quality metrics, care coordination metrics, volume, labor, and finance metrics. And we will bring those back, what we looked at last year as the baseline, as well as where we are this year when we bring this presentation back next month. Next slide, please. Okay, now we are really getting into the meat of the presentation. And if you look at this slide, there is somewhat of a legend at the very bottom of the slide, right next to the star. And we have 17 community need areas, so there are 17 slides like this one. And we're not going to go through all of them today. We're going to go through about half of them today. But there is a slide for every community need area. And we consolidated some based on services, cross-functional areas, and budgeting, but we've got 17. If you look underneath the community need area, it addresses the initiatives, and these track back to slides 4 and 5 at the beginning. So you'll have a community need area and the initiatives in them. In the top row, it goes year by year by year. In the next row, it's got either estimated planned spend or actual budget costs. So if you look at for fiscal year 2024, that is the actual spend that we had in fiscal year 2024. Fiscal year 2025 is either what we've spent to date plus our potential estimate. And then we will bring back, as we move forward with the budget planning and forecasting for next year, information about 26, 27, and beyond. And really what we are trying to show here is what is the equity plan going to cost, what's been done, what's left. If you look in each column, this is the work that has either been done, like in 24, 25, we have work that's planned for 26, and then for 27 and onward is work that is potentially in progress. The outcome metrics are measured, are highlighted in the bottom kind of left-hand corner. There will be something that says outcome metric, and then if you look at a star next to any initiative, then that means it's a new investment, and major investment or resource intensive items are included. Not everything that we've done is listed on this, but these are resource intensive new items that were worth highlighting. Oh, and just some of the abbreviations right out of the account. There's something that's called a BRKR. That is a budget resolution key result that tracks to the budget resolution priorities. And then there is a health equity, when it says HEP, those are healthcare equity plan KPIs.
So, I have a question quickly. So these are, okay, this is the budgeted for 2024.
No, ma'am. That's
Expenditure?
Actual
So the-
for
the-
2024.
These are
Yeah,
actuals,
so
but
the
can you,
budget, if you go back to slide 4 in your packet, that would show you the anticipated plan cost for that item. So for that first slide, the anticipated cost was going to be 12.2 million. And then the actual cost in FY '24 is what's on this slide 9 that you're looking at, the 13.9 million.
so, okay, well
And
that's,
some are gonna be over, some are gonna be under, timing differences, other things that were expedited, some of the unanticipated costs.
would you be able to break down the cost for these service lines? Because this is the big bulk yes, Manager Rodriguez?
Can I add to, that's drilling down, as we're describing the word, but I was just wondering on the very top if you could do the one-time cost and the recurring cost, because that would show us exactly how much we're adding on every single year. And the one-time cost would be if there's any one-time cost, for example, in the FY '24 achievement, so that 14 million, a one-time cost, I don't know what that would be, but the recurring cost, it would just be helpful from a tracking governance perspective.
Planning is a one-time cost will be,
Right.
Almost everything on these slides, except for the very last slide, are going to be operational costs and are likely to be ongoing. And you'll see on this particular slide 9, a lot of the things that we implemented at Central Health in FY '24 then start to show up as full year costs in FY '25. So where that was 13.9, it becomes 21.8. All of the capital expenses, those one-time expenses, are on the very last slide.
Got it.
Most of these are not gonna be one-time expenses.
Thank you, because that I was trying to read it, whether it's recurring costs or one-time and how to pull those
These are
out.
almost all operating costs,
Yeah.
and the vast majority are going to be associated with staffing or contracted services.
That's a little different than what,
yeah, because I think it would be helpful to know which service line is really big bulk of investment that we're adding. So maybe you don't have accurate number, maybe percentage wise what it is, attributing to that actuals. Like for instance, like I don't know, continued dialysis expansion including home dialysis. So I know this is a need. Like how much have you invested in this? Sometimes it might be financial expenditure, but we've hired previously physicians to take on some of these roles. So I'm just trying to think about terms of, I know we're going in the details of these investments, but it'll be helpful to know percentage-wise or cost. Yes, Manager May?
Would it be helpful if, and this is a question for all of us really, would it be helpful if the information was presented like in a pie? Versus down like that, versus, this is good, I'm not suggesting that it's not, it's very helpful, but given the level of information that the chair is talking about, might it not be easier to present the information if you're doing it in a graph, like a pie shape or however you think is the best? Because what I'm seeing in my mind, you're taking all this data off of Excel spreadsheets. I mean,
It's
different
coming out-
pages.
Largely coming out of our accounting
Right.
software, and that's one of our big challenges, and I can just make two observations. One is that we want to be careful that we're not misrepresenting anything or double counting it.
Yeah.
And part of our challenge in putting this together, it was a very manual process, but it's coming from our accounting software. How we budget has evolved since we did this plan. So how we budget and capture costs now doesn't necessarily align with how we were budgeting at the time.
Yeah.
So we're having to go in and take, our transitions of care team is a good example. We have our hospital-based teams, we have our skilled nursing teams, we have our care at home teams, we have case management. How those were budgeted all in one department back when this plan was put together is now very different. And so we're having to go in and try to grab different pieces. And
It's almost like a Band-Aid approach.
my fear is that we either double count something or we
No,
leave something
you
out
won't
if we
do
get
that.
too detailed with that. The more detailed we get, the higher the risk is
Yeah.
that we
For
miss
error.
something.
And so another thing, are these listed in terms of priorities, hierarchy, or is it just random? Like the listing?
Yeah, it's not in any particular
okay.
order.
Right.
I think we can.
Just wanted,
We can maybe try, as we're presenting, try to outline where the majority of the costs are, at least anecdotally, and then we can always, I think we need to go back and look at what additional detail we can provide in terms of numbers to supplement that.
and
And
also to
I do
include,
think, but may I just, for Manager May's question, I think one of the things that we could do looking back, so retrospectively, like John was saying, it might be more, wait, let me answer the pie question first. I'm sorry, I don't want to miss the
You're
pie
stuck on
question
that one.
because I don't want to skip past it. I think one of the things that we could do that might be helpful for visualizing the level of detail, particularly retrospectively for 24 and 25, is we could do a pie visualization of 24 by community need that can show you kind of at a glance how each of these investment areas are weighted. So we could do a pie for 24 and you could see at a glance whether it was weighted towards specialty care or mental and behavioral health or, healthcare for the homeless, things like that. So I do think that it would be helpful to do a 24 pie and a 25 pie that kind of shows this at a glance. And then I think it would be looking forward to 2026 as we're forecasting for what we would be recommending for next year. We probably would have a more accurate depiction because we're not having to try to cobble something together from past accounting systems, but we are looking at kind of the process for recommending budgets for next year and doing the forecast. I think we could get to the level of detail for initiative by initiative looking forward to the 26 line. if that makes sense.
It does, and also I would hope you can also include Manager Rodriguez's comments, a one-time investment or ongoing. I think that distinction will be helpful. And Manager Jones?
Yes, am I overlooking, is Colony Park indicated in here?
Not on this particular slide. This is for specialty care specifically.
And we're not
Uh,
going to have any,
That'd be primary care.
It's primary care, dental services, and mental health, I believe, and pharmacy.
oh, okay, all right, I thought we were having some there.
But that has started anyway. But that is gonna be on slide 13.
Yeah.
So there will be,
Constructed.
Colony Park is in the presentation.
I have a quick question.
Yes, Manager
Mine is
Valdez.
very simple, and probably so simple, I'm gonna be, everybody's gonna laugh at me for asking it. Down here at the bottom where you have your breaker and your HEP for the two acronyms, where would it show up here? I see how you've done the stars in which programs, but where, because I don't see one that has a breaker or a HEP.
So that would show up, our first one with a breaker and a HEP would show up as an outcome metric on slide number 12, which includes the post-acute care, which there is a healthcare equity plan KPI related to medical respite bed days.
Okay, I'm on
And so
12. Where-
that
maybe I'm blind.
shows up there. And we included the legend for
I see.
everything on every slide, even though there might not be a star on every slide or, yeah.
Well, I see you have it over here, and to me, it looks like it could be a legend, as opposed to here, where the stars are showing up in the body of the document. So that makes sense.
So-
Thank you.
That, if you could please kind of put that somewhere.
Thank you, Manager Valdez. So I want to ask if anyone has any further questions on the slide. I think this is appropriate time to pause right now because I think the rest of the KPIs are similar, the way your format. I think providing some feedback to you in the future might be helpful as when we bring this back again. Would that be
Can I
fine?
say one thing?
Yes.
I just want to say thank you, guys.
Oh, yes.
Y'all did a whole lot of work on this, and I know you worked really hard to get this to us today. And just think, you won't have to do it tomorrow or the next day. So even though we didn't go through it all, so we're now at the point where we're gonna be able to really dig in and understand this. This is excellent. Thank you.
Yes.
Are you asking us to, we haven't even gotten to the good stuff yet.
Well, no,
Yeah, we're
I
asking
know
you
that
stuff.
we have a lot.
Okay, no,
We have
I appreciate that.
Time, I just want us right now, I'm gonna go around the room to see if there's any comments, and we also have a motion on the table as well that we wanna take. So I'm gonna start with Manager May. Do you have any comments or questions on how this is going to be presented to us?
No, I do look forward to being, I appreciate the work, of course, because I know it's a lot of work. But I do look forward to being able to see more graphs and more charts, pie charts, things like that. I think it's easier to digest that level of information, because it's a lot. Thank you.
There is a lot of content.
Yeah.
Yes. Thank you, Manager May. Manager Jones?
I just echo what she said. I think it's a great work, a lot of information. We may understand it. I think the public will have challenges with some of this information, but good work, and to the degree that you can coordinate it, I think that would be good.
Thank you, Manager Jones. Manager Motwani?
Echo appreciation of the work. I do understand the challenges. I mean, it's in this year and time, still getting stuff out of the accounting system into a digestible format is so stupid. I don't know why it still does that. And beyond that, like just being able to track these variables, you know, you can't do it in the accounting system. The budget, the budget resolution KPI, and the the equity plan, indicator, and all these cross-referencing variables, and then putting it all back together. So I understand that nuance. I really, really appreciate this format. Thanks.
Thank you. Chair Kitchen?
Just thank you. This is very helpful for us, to understand along with you about where we're at on the health equity plan. So it's really good, solid work, and we will do our homework and read this stuff and work with you on it as we move forward.
Dr. Brinson? Thank you. Your microphone.
Thank you. No other comments. Thank you.
Thank you. Dr. Martin? Manager Valdez?
I want to know when we can enlist an AI person to calculate and design the way it's going to be provided to us. Thank you.
In the near future, Manager Rodriguez?
Was that a motion about the AI?
Got the
No,
money?
I just, thank you. Well, does everyone else appreciate
So-
the work?
Thank you all. We have a motion on the table. If members, did you have an opportunity to read this motion? Would you like to read it, Chair?
Yeah, I'll need to make the motion.
Do you want to put it, and then we can. Here, if you want.
Chair, I'll be happy to make the motion. I move that the committee recommend that the board ask staff to instruct staff to annually review the district's progress on the healthcare equity plan prior to each budget cycle, with the first such review to be performed by first quarter of fiscal year 26.
Do I have a second? Manager Valdez, do you second it? Yes. Any questions or comments related to this motion?
I'll just add, this is something I know our staff intends to do, and it's a way for us as a board to market as something that will be important for us as a due diligence on our part as we go forward with our budget every year. So thank you.
Okay. Yes, Dr. Martin?
As such, I would like to really emphasize that this be presented to the people who sign off on our budget. This data, that this be presented to the people who are signing off on our budget. These metrics that we're achieving. It's very, very important data for them to see objectively
Absolutely.
what's happening, so that's all.
Absolutely, and hopefully it'll be in a format that is digestible and easy to understand. Do I have any comments or questions? I see none. Now,
Oh, actually, I do.
oh, you do? Manager Maloney?
Just curious if this, I mean, is this, so this will become sort of an annual compliance item that we need to check off? And then the format is TBD, I guess, or just as it's ad hoc form, I mean, it's basically, are we gonna finalize a format for this? How this needs to be reviewed, or it just needs to be reviewed?
I think a formal review is appropriate.
Okay.
So I didn't take the vote. Did I take the vote? I did not, so, all in favor?
Aye.
Aye. So, thank you, the motion carries. Thank you all. Now, we're gonna pause here. Is Dr. Zamora present?
Yes, yes.
So, okay, so we're gonna pause here. It's 5:32 p.m. It's May 28th, 2025, and it's 5:32. So I am gonna recess the Budget and Finance Committee.
Do I need to open Board of Managers, or do we just do this? Okay. Managers, it's May 28th, 5:33. I'm going to call to order the meeting of the Board of Managers. And our first item that we will take up today is our thank you to Dr. Zamora for his many years of service on the Board of Managers. So he will be in a minute, and then we'll get started on that. We have.
We have one.
We have.
They're ahead of you.
Yes.
Totally ahead of you.
So, when he gets in here, let's see. Because one is from the state. I can't find my script.
You got buried in there.
Oh, here it is. Dr. Zamora, welcome. If you will have a seat with us, we have a right there on the end, or wherever there's room for. No, right here, right here. Okay, she can sit with you if you'd like.
I'm so glad you don't have a cane.
Yes, because we're about to give him one. So Dr. Zamora, thank you for being here with us. We have our CEO who's going to read a resolution that we have for you. Dr. Lee, would you like to go ahead?
Sure, I'd love to. Good evening, managers and colleagues, Dr. Zamora and Becky. I'm so sorry I can't be there in person, but I'm really delighted that I have the opportunity to read this resolution on behalf of Central Health, expressing our deep appreciation to Dr. Zamora. So here we go. A resolution expressing appreciation to Dr. Guadalupe Pete Zamora, MD, for his service as a member of the Board of Managers. Whereas Dr. Zamora served as a member of the Board of Managers of Central Health since 2013 and was chair in 2018 and 2019, and whereas Dr. Zamora has honorably served as a healthcare professional who embodies the highest standards of care, compassion, and professionalism, and whereas Dr. Zamora is a beloved East Austin family practice doctor whose decades of service have improved the health and well-being of patients with low income in our community, and whereas Dr. Zamora's deep empathy and commitment to his patients have earned him the admiration of colleagues and patients alike, and whereas Dr. Zamora's contribution to the community extends beyond his medical practice. For more than 40 years, he has been a core member of various organizations dedicated to improving healthcare access, including the Medical Access Program Advisory Board for the City of Austin in 1978, and the Travis County Medical Society, where he served as treasurer, secretary, and president, and whereas Dr. Zamora's advocacy for quality healthcare for all, along with his role in the establishment of Dell Medical School through the Healthy ATX Board, the community of organizations created to foster the creation of a medical school at UT Austin, has profoundly impacted the lives of Travis County residents. And whereas Dr. Zamora continues to serve as a clinician and mentor to a number of physicians and healthcare providers, and whereas Dr. Zamora was the recipient of the initial Healthcare Champion Award on the 20th anniversary of Central Health, and whereas Dr. Zamora, through his leadership and example, has positively impacted the health and wellness of generations of Central Texans with achievements in preventive measures to improve health and wellness of his workers and his patients, and whereas Dr. Zamora generously shared his talents, skills, experience, and leadership for a prestigious career in public service and healthcare excellence, and whereas Dr. Zamora has demonstrated unmatched commitment, devotion, and dedication to health equity, therefore, be it resolved by Central Health that the board expresses its sincere appreciation and gratitude to Dr. Guadalupe Pete Zamora for his dedicated service to all the people living in Central Texas.
So,
as we are standing to look at tomorrow,
so managers, we're not finished. So, Manager Valadez would like to make a motion that we adopt the resolution, right?
So moved.
And seconded by Manager Martin. Okay, all in favor?
Aye.
Okay, Dr. Zamora, we have a resolution for you. We have the flowers. We also have a gift. The Physician Public Service Cane from Central Health, which acknowledges your years of service to the Central Health Board of Managers, and will be engraved with your famous saying, "It's all about the patients." We also have for you, Dr. Zamora, we have a resolution from State Representative Lulu Flores. She was not able to be with us tonight to present it herself because the legislature is meeting this evening, as we all know. So we have a resolution for you also from the House of Representatives. So everyone, I think would like to take a picture. Can we do that? Should we have it? Oh, yes. Yes. Would you like
I
to?
do. Once again, thank you to each and every one of y'all, because y'all made me here and made me better with working with every one of y'all. Thank you, Pat, for those kind words. Those are beautiful words. But my better half is next to me. And without her, I couldn't do these things that she allows me to come and help the community. Because it's about the community. It's about giving back to who supports us. I can't thank y'all enough. Those are all kind words and kind gifts, and I will always remember you. And And please, my ending words was, it's about what the patients need. Thank you.
Just that I'm very proud of him, all the hours he put in, which all of you know. And I can't, I love him, but I knew this was dear to his heart. So I'm happy. I'm happy for him.
Thank you, my love.
Okay, let's take a
Bravo.
picture, and I think we have cake also. Where would you like us to be?
We should do it in front of here. I'm gonna move some of the chairs.
Okay, okay.
No, but I'm gonna think about it.
Oh, he's got it, he's got it. Here you go.
So if we could all, squeeze towards the middle. And you could shift this way so it's.
We're too long. I mean, going too long over there.
Yeah.
Needs to be more centered.
Here, you wanna, wait.
No, get over here.
You wanna get here?
We might have to double up.
Where's Becky?
Becky, go over.
Can we structure it by?
You want me to, yeah.
You just tell us.
Get on our knees or something?
Here, do you make it go over there?
Let's shift this way, Jeff can be.
Shift to y'all's left.
You can be next to
Move
me.
over.
Yeah, you'll be right here in the center, perfectly in the center. Yeah.
Okay, everybody turn sideways.
Yeah.
So we fit, so we fit.
That looks good, looks great.
Where's the other?
You go for it first.
Well, go ahead. I'm just gonna, you're the main one.
I got you. All right, here we go, right here on three. 1, 2. Got it.
We do one more. All right, now, set chair.
Thank you. Dr. Faith, thank you for everything.
Thank you. I'm so glad that you're feeling better, and thank you for everything. So good seeing you.
I'm still doing therapy, so I'm still gonna miss the meeting tomorrow with,
Oh, you are, okay.
but
It just really shows you the colors.
Congratulations. Congratulations. And thank you for everything you've done. How much time for you want? But we have cake.
Okay, we've got cake.
Okay, everybody, let's take about 10 minutes. We'll start again at 5 till, but we have cake. Join us for cake.
Pete and Becky, I love you both. Sending you electronic tag. Sorry I can't
Pat,
do that
we'll
with
have
you in
some
person.
cake for you. So let's start.
thanks, Pat. Thank you, man.
Thank you for everything. Very concise, confidential commentary.
budget and finance.
Yeah,
Okay.
it's gonna be short, not long. Okay,
But we
great.
haven't formally closed, right?
So we are reconvening the Budget and Finance Committee. Today is May 28th and it's 5:55 PM. We are gonna go into closed session to discuss item number 7. Receive and discuss a presentation on an overview of legislative and regulatory issues impacting central health. I announce that the committee is convening closed session to discuss agenda items number 7 under Texas Code 551.071, consultation with attorney, and under Texas Government Code 551.085, governing board of certain providers of healthcare services. Thank you. So, we're going to close. Let me know when we're ready. Thank you. So we are out of closed session. We discussed item number 7, and there's no motion necessary for that. Moving on to our agenda number 9, confirm the next Budget and Finance Committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, June 25th, 2025 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment. Manager Valdez moves, second. Dr. Martin seconds. Any discussion? No? All in favor? Aye.
Okay, managers, I'm gonna call back into order our Board of Managers meeting at 6:26 on the 28th. The first item is public comment. Do we have any public comments tonight? No? Okay, we're gonna move on. We're gonna now proceed to the consent agenda. Members, consent agenda items C5 and C6 will not be considered and will therefore not be part of the vote on the consent agenda. Item C5 was not taken up by the Budget and Finance Committee, and C6 is not ready for consideration yet. May I have a motion for the consent agenda? So, motion by Manager Valdez, second by Manager May. All in favor? Aye. Okay. We will now move on, proceed to the regular agenda. First item that we will proceed to is receive and discuss a report from the President and CEO. Dr. Lee. Dr. Lee, are you ready to present? Let's see, is he? Dr. Lee? Oh, I think he's frozen. He's frozen. Okay. Can someone,
Good evening, managers. Are you able to hear me okay? Sorry,
now we can. We couldn't for a few minutes there, so, yes.
Okay.
Please proceed.
Perfect. All right. Good evening, managers. Pleased to provide this CEO update. Item number 1 is our priorities and key results. You received a detailed written copy in the backup. What I will do tonight in the verbal comments is provide a high-level overview, beginning with the budget resolution key results. We are on track for all of the budget resolution key results except for a couple of them. The first is that with the respite construction at the CEC, there have been some permitting delays that have set us back about a month. And so what you see here is a projection that we expect to have about 2 months of clinical operations before the end of the fiscal year instead of 3 in the respite, and therefore we'll be a little below target in terms of bed days. But the team is prioritizing making sure we get the work done right rather than trying to rush it in order to hit the numbers. So we're about a month behind there. Regarding the social determinants of health key results, we have actually developed the goals around mobile food pharmacies and medically tailored meals and plan to launch in June. However, there's been a delay in selecting the vendor due to some nutritional requirement considerations, and therefore that item is yellow. As I said, the other items are green. Shifting over to the shared system priorities and key results, there are 19 total key results here that the board has prioritized. 12 of the 19 are green. 3 of the 19 are actually yellow or red because, as you are aware, there's been a leadership transition of the COO at Community Care, and Nancy Baum is a key owner of these 3. So we are sort of recalibrating and getting back up to speed quickly, but those 3 are delayed as a result of the leadership transition. There's also a good progress on describing the future integrated care system with the opportunity to potentially learn from a powerful visual that University Health has used for some time, and we may be adapting this for our use. There's also a key result around really deploying the management by objective goal through the different executives' departmental lines. And so we're a little bit behind on that one, but good progress being made there as well. So those are the 2 updates. We're a little bit delayed on the system objectives and key results. Moving forward to leading edge, the Bridge Mobile now has active sites at the Integral Care Diversion Center and Hungry Hill. the Texas Harm Reduction Alliance in March, and the Foundation Communities Waterloo and Bungalows in April. And so we are providing medical care to patients at these specified outdoor and indoor locations alongside our colleagues in those facilities, really blending and connecting our services with our partners. The next step is around psychiatry services. We've expanded those services to Rosa Zaragoza to now include one physician and one advanced practice provider. We are receiving referrals from 7 different service lines there. The emerging issues we heard about just recently in the closed session with the Budget and Finance Committee. Moving on to outside, inside. You have a longer written update here, but a couple key points. On April 28th and 29th, there was a joint CEO huddle between Dr. Yagoda, Sharon Alvis, and myself, where we really talked about the goals and the next steps in terms of system integration, and met with hundreds of staff from all 3 organizations to further support ongoing internal communication. There's an FAQ page and resource hub that's now up on the internet. There's also a condensed version of the panels in about a 2.5-minute video that staff have been viewing for those who weren't able to make it to the actual town hall. We will continue a thorough internal communication cascade likely over the coming months. Continuing on the internal updates, Lucas Bustelo has been appointed to the Chief of Staff role after 3 months of serving in an interim capacity. He's doing a terrific job, and I just want to congratulate him for all his effort. I think I speak on behalf of our whole executive team. He's done a great job. In terms of outside transitions, some key leadership transitions that you've likely heard of but should be aware of. At the UT system chancellor level, J.B. Milliken is transitioning to the University of California presidency effective August 1st, 2025. And Dr. John Zervos has been appointed as the acting chancellor beginning in June. At Ascension, Texas, the next president's been announced. That'll be Jamie Youssef, coming to us from HCA, bringing over 23 years of experience both at HCA and Ohio Health. He assumes the role in June 1st. And then at the UT Dell Med School, the Chief Business Officer and VP of the Health Enterprise, Martin Harris, has announced his retirement at the end of calendar year 2025. In terms of community conversations, we had the Precinct 3 conversation on May 7th, and Precinct 4 at the Manor Lions Club is scheduled on June 5th. There was a wellness fair hosted by the Community Health Champions together with the Foundation Communities team. This was at Blue Bonnet Studios, a PSH site in South Austin, and it was organized by alumni of the Community Health Champions program. Community members received basic health screenings, nutrition and healthy cooking demonstrations, financial wellness resources, employment readiness support, and even a free yoga class. There were a total of 50 attendees from across 4 different Foundation Communities sites. We had a CEO roundtable on May 20th, where we had 18 community leaders gather to hear an update on the strategic plan and our integration plans. This continues to be a really positive and well-received means of engaging with some of our closest community stakeholders and allies, and a very diverse group around the table. Kudos to the communications team for keeping those going. On to what we're solving for, and a view to the Flat Factory floor. One of the innovations that Kim Heine is working with our infrastructure team around has been a supply chain process that we call a two-bin process. This is a process to really streamline ordering, receiving, storaging, stocking, and making it really easy for us to see what we need and what's missing. And so this involves establishing baseline for what you need to use, what safety stock supplies need to be, training all the clinical staff who use those stock rooms. And when that training is complete, we're ready to begin going live. So excited to begin to implement some of these core practices that lead to operational effectiveness. And then finally, we have a mission moment on highlighting our medical weight loss optimization program, which I'll turn over to Edwin, I believe, to go ahead and share that with you. Thank you.
My health goals for medical optimization is obviously number 1, to start learning to eat healthier. 2 is to control my diabetes. and my A1C, which I kind of did today. So I've lowered it, but you know, a lot of work there that needs to be done. You know, and I just want to feel better.
My health goals are to lose weight, to feel better about my body, and just feel healthier, feel like I have more energy.
This is an opportunity, particularly for weight loss. Obesity affects so many different chronic health conditions like diabetes and heart disease and high blood pressure. In fact, sometimes you can cure some of those conditions just by losing 10% of your body weight. So this is really an opportunity to do some lifestyle change and some education and some treatment to help reduce the weight, but also help with some of those conditions that are related to it.
I basically want to get back into shape. Previously to this, I did lose quite a bit of weight, but now I'm finding that it's a bit more difficult for me. And so this was one of the reasons why I was a perfect fit for this program.
A successful result would be like losing weight and keep having it stay off, having like healthy habits that I can stick with like daily and weekly.
I wanted to join this medical optimization program because of the fact that I am 49 and not getting any younger. In a couple of months I'll be 50, and I really want to start taking care of myself, you know, and I want to learn what is affecting my conditions. I am a type 2 diabetic, and I've noticed that my sugars were just unchecked and uncontrolled, and obviously it was due to the eating.
So today we attended our third class of our medical optimization class. The class was focused on the hunger scale, so kind of trying to be more in tune with your body. We also did a lot of mindfulness, a lot of breathing techniques just to kind of give yourself a little bit of a break when you're like, I'm really hungry, I'm eating this.
Today's class is really helpful for me. Something that I struggle with is like fullness and like hunger and like not waiting too long to eat and then eating too much.
One of the takeaways for me personally is to like literally slow down and kind of enjoy the food, if that makes sense. We did an exercise where we took an orange and we peeled it. We were feeling the outside, the smell, the taste, and all those components in terms of eating. For me, it related because I'm a fast eater. And so it kind of just tells me, hey, you know, just kind of slow down and enjoy and eat and then let it process. And you know, that's kind of was the bigger takeaway from today's class, I thought.
Great.
Okay, 2-7. Oh.
I can't help but just observe as a primary care physician that I just love the way that medical optimization program is not just about the medicines. You know, it really is about whole person care. Meeting people where they are and really thinking about all the aspects of, you know, do we help you feel seen? Do you feel empowered and engaged? So just want to compliment the team. And thanks again for the opportunity to provide this update.
Thank you, Dr. Lee. I'm going to take just a second to let people know because everybody looks like they're wondering. Ted, could you just read that to them?
Severe thunderstorm warning till 7:30 with possible baseball size hail.
Oh, just baseball size hail, that's all. Okay, but it's, the alert is through 7:30, right? Okay. All right, so we're going to move on to item number 3. Receive and discuss a progress update on fiscal year 25 strategic priorities and fiscal year 26 system objectives and key results planning. So that's Dr. Lee, and I think, Kim, are you participating in this? Okay, so Dr. Lee, again, you know, we're looking at time here. This is an important one, and I'll let Dr. Lee talk with you about this. He's wanting some guidance from us, so this will be an important one for us to look at, and if we're ready, we'll take a motion on it. So, Dr. Lee, you want to go ahead, and Kim, y'all want to go ahead?
Please. Let's go to the next slide, please, Brianna. So actually, I've been listening very carefully to tonight's discussion. And there's been a very appropriate and important discussion around how we prioritize amongst the many needs before us, how we are mindful of the financial outlook before us, how we focus on the outcomes that matter. and reminded that it's often said that strategy is about what we choose not to do in order that we can do the most important things. And therefore, one of the most important questions that we need the board to weigh in on is, what is most important? What do we want to accomplish in FY26 that can serve, therefore, as a lens, a critical lens into budget prioritization? There are, I can share with you now, there are many more good ideas for this year, both internally and externally, that we can possibly fund. Perhaps several times more need than we actually can responsibly spend. And so we really do need the board's input, and we've had a chance to preview a couple different times with Chair Kitchen and Vice Chair Brinson, which you're about to see. But if possible, we would really like the board to provide direction or action tonight, if possible. And so what follows is system-wide goals. Sendero, CUC, and Central Health, a collaborative approach and a continued evolution of our strategy and planning process. So without further ado then, we are pleased to recommend to the board that we consider FY26 as the year of access, a year where our community, our respective boards, all three boards, and our respective teams think about the challenge before us and the opportunities of our integration and what is most important to our patients, and actually focus in a fairly laser-focused way on access. So let me take into what that looks like. Next slide, please. This is a framing slide. These things are always true, but are important to say. We need to be ferocious advocates for our mission to improve the health of our community by caring for those who need us most. At the same time, we have to be wise and dedicated stewards of our resources, because there's no mission without our margin. We have to be stewards now and for the future. Next slide, please. So similar to the FY25 process, we got all the top leadership together across all three organizations, closed the door, and asked folks what is most important. And these are the key themes, the key areas of focus, excuse me, that came forward, and I want to share them with you today. One second. My apologies.
Yeah, Dr. Lee, could you speak up a little louder? We're having a little trouble hearing you.
Definitely. Yeah, my apologies for the coughing there.
No, it's just because the rain is so loud. So go ahead.
Okay. I heard it's a 3-inch hail, so that might not be rain. So priority number one, and what we're really here to do is provide access to the high quality care across the full care continuum. The second real focus area is on one team, becoming one team and really integrating this system and discovering all the synergies and possibilities and cost savings that are possible there. And the third, underlying all of this, is the financial sustainability to do this this year and carrying forward, wisely managing our reserves and our resources, as there is no safety net beneath our safety net. Next slide, please. So you see here 6 different stretch goals that relate to the access component of the year of access. I will note these are intentionally ambitious targets that we are setting to inspire breakthrough performance. We expect to refine as we progress, and for some of these metrics marked with an asterisk, these are preliminary metrics that require further validation as we benchmark and determine our measurements, but we wanted to put them before you for your consideration today. And you see in the top left there what we're calling our moonshot goal, called out in orange. This is a goal that I don't think we will accomplish in the coming year, but it is a goal that if we strive for it mightily, it will potentially focus our efforts. It will speak to our community, I believe. It will be meaningful in the terms that matter most. And so this is to reduce the appointment wait times for our patients to 2 weeks or less. I can tell you now that the wait times are longer than that, as you may well know. And this will require us to likely make a great deal of changes relating to our care model, how we work together, how we link processes, how we flow without waiting, how we manage our variation, how we manage our demand and capacity matching, and so on. But this is the goal that matters most, we believe, in the year of access, to reduce those wait times to 2 weeks or less. Additional goals are to reduce avoidable readmissions and ED utilization by 10%. This really speaks to the most complex patients, our patients who are homeless, who have dialysis, congestive heart failure, so on. A lot of the work that we're doing around transitions of care, skilled nursing facilities, dialysis, street medicine, jail medicine, mental health, addictions, and so on, will end up showing up to some degree in this goal. The third goal is to increase the number of unique patients with coverage by 5% over today's current state. So that includes all the different forms of coverage that our patients receive, whether that's Medicaid, MAP, MAP Basic, Sendero. So thinking about this as a global goal across the system. The next goal is to close 3 meaningful quality care gaps by 15%. And so, at least one of those, I hope, will be related to cancer, but we will drill in and determine which ones we'll focus on. The fifth goal, and these 4 above it should hopefully contribute to this, to really increase patient satisfaction, measured by patient net promoter score, which is a difficult measure to move, but one of the gold standards out there, to increase patient NPS by 5% or more. And then to increase community support for central health by 5% or more, related to all these goals above. So the year of access, this is the main focus. Next slide. In terms of the one team system integration, here we have some of the people goals to really improve the team member satisfaction score by 2%. This is actually both the goal to establish a unified system measurement approach, which we don't have today, to get that baseline and then to improve. This can be a very difficult metric to move. 2%, I believe, is actually quite meaningful here. And one of the key drivers to that satisfaction is a sense of belonging, especially now, given the conditions that we all face. So to increase a team member sense of belonging by 5%. These things should contribute to the ability to create a culture that allows us to increase new hire retention by 5%. And this final goal around leadership and management participation in the cascade of these most important priorities and key results to over 75%. This is to to really practice and develop a habit around the management system that the best world-class companies anywhere around the world in any industry actually use to practice. And we want to bring this into our core practice in the coming year. Next slide, please. And finally, financial sustainability. All 3 of these goals are potentially quite stretch goals. So to increase our non-tax revenue sources by 2%. Again, this is a quite large number when you think about our overall revenue and what percentage of it is non-tax based. 2% of that number is a large number, many millions of dollars. The second goal is to reduce duplication of functions and services by 50%. We would have to actually inventory all of the opportunities for deduplication and then try to move half of them into a unified approach. We might not reach that full goal, but it's worth striving for. And one of the effects of this would not only be a more streamlined process for our patients, but likely an overall reduction in our cost and what it would take to accomplish our core work as we go from 3 ways of credentialing to 1, for example, or 3 different revenue cycles or eligibility processes, and so on. And finally, to achieve average system-wide resource utilization of 75%, also a very difficult goal. But if you were to stand